is 2 years. 2 days, I'm sorry. Today we have mostly we are concerned all the subjects that are presented, our lecturer are presenting is about aesthetic dentistry, of course, and especially with digital instruments, digital technology. Our first presenter is Dr. Mahia Hassanzadeh, Assistant Professor in Department of Orthodontics, School of Dentistry, Tehran University of Medical Sciences. Her topic is dental materials in digital dentistry. Okay. Dr. Hassanzadeh, good morning.
Good morning. Hope that
we can hear you. I think your microphone is not on.
Can you hear me?
Okay, Dr. Hassanzadeh, please start your presentation. The screen is yours.
Good morning from Dental School of Tehran, University of Medical Science. I hope that you have enjoyed the first 2 days of the program, and let me start the third day with an interesting topic of calcium ceramic materials. First of all, let's answer this question: how do you usually choose your restorative material? To be honest, clinicians usually choose the restorative material based on the preference of their dental technician in the advertising claims of the manufacturer, or that regarding the consistency of the material, and the selection is seldom based on the true understanding of the characteristics of the materials. This is why huge number of products are available in the market, and the speed at which the new materials are introduced into the market makes clinicians complex decision regarding choosing or selecting a restorative material for a particular purpose. So let me start the lecture with a quick review of the ceramic classification according to their composition. If I want to classify the ceramic according to their composition, I can divide them into 3 groups of glass matrix ceramics, polycrystalline ceramics, and resin matrix ceramics. Glass matrix ceramics are inorganic non-metallic ceramics that contain glassy phase. When I say that it contains glassy phase, I mean that you can etch it, so you can use them as a bonded restoration. Polycrystalline ceramics are inorganic non-metallic ceramics that do not contain any glassy phase, so you cannot etch it, and so you cannot use this restorative material as a bonded restoration. And finally, the recently introduced resin matrix ceramics is a combination of the polymer or resin with the ceramics. So we have the benefits of the flexibility of the resin or polymer with the strength of the ceramic, which is combined in one material. The glass matrix ceramics divided into 3 groups of feldspathic ceramics, synthetic ceramics, and synthetic ceramics is composed of lithium disilicate ceramics, zirconia reinforced lithium silicate, which we are going to talk about, all of these materials, and glass infiltrated ceramics. And polycrystalline ceramics is divided into 4 subgroups of alumina, alumina toughened zirconia, zirconia toughened alumina, and stabilized zirconia. As I told, all of these materials do not contain any glass phase, and so we cannot etch these materials. And finally, the resin matrix ceramics is divided into two subgroups of resin nanoceramic and polymer infiltrated glass ceramics. As these materials combine both polymers and ceramics in one material, we also call this material as a hybrid ceramic. First of all, let's start with telescopic ceramics. We knew telescopic ceramics for years as a veneering material on the metal substrate or on the zirconia substrate, or even as a bonded restoration for aesthetic purposes. And telescopic blocks also are similar to the conventional telescopic powders, but they are produced in a different way. We know them as an extrusion molding. It may be interesting for you to know that the first ceramic CAD/CAM restoration that was made in 1986 was a telescopic restoration, and the commercial brand was Vita Mark I. Vita company introduced Vita Mark I as the first CAD/CAM block, and the first restoration was fabricated in 1985. And after that, Vita company introduced the second generation by Vita Mark II. Mark II was again a telescopic block and have a flexural strength about 100 megapascal to 160 megapascal when glazed. Just keep in mind that when I reporting the flexural strength, this flexural strength is according to in vitro studies. But if you want to evaluate the dental material, it's better to search about the clinical performance of the material. So if we search regarding the clinical performance of the telescopic blocks, we find that the survival rate after 5 years is about 95%, and after 10 years is about 86 to 89%. This seems good and acceptable for dental purposes. If I want to have a quick look and summary about the characteristic of the Vita Mark II, Vita Mark II is a telescopic block from the Vita company, and the strength is about 160 megapascals, and it's a one-step material. What I mean by one-step material, I mean that we can design your restoration, mill your restoration, polish it, and stitch it without any further heat treatment, or we can put it in the furnace and glaze it. So glazing is the optional step and it's not essential. So we call this material as a one-step material. And Mark II blocks are available in different sizes and shapes. We usually choose the size of the blocks according to the size of the restoration. The smaller restorations like inlays, onlays, or endotrans is a smaller block size, and much more bigger restorations like crown of the molar needs blocks with a bigger size. And also the different shades is available for Vita Block Mark II. And about the indication of the Mark II blocks, the telescopic block is indicated for inlays, onlays, crowns, and veneers. And whenever you have an enamel around your preparation, you can use telescopic block and telescopic restoration, and it will be blend perfectly to the remaining of the structure. The next generation or the next product of the telescopic blocks from Vita company was Vita Block Trilux and Trilux Forte. So what's the difference between Trilux and Trilux Forte and the previous telescopic block that I talked about in the previous slide? Is that the Vita Mark II was a monochromatic block. It contains only one hue and one chroma and one translucency, but Trilux Forte and Trilux contains different layers with different intensity and translucency. So in Trilux, we have 3 layers. The top layer or incisal layer or enamel layer is more translucent. The middle layer, which is like built-in or body layer, and the bottom layer or cervical layer is more opaque. So you can have a more aesthetic restoration and further layering or staining is not needed. And 3D sport is more finely nuanced and it could be used for multi-layering restoration. And whenever you have aesthetic purposes, you have two restorations in the aesthetic areas, you can use these blocks. In this slide, you can see that the restoration is designed in the blocks, and you can freely move your restoration in the blocks, and so you can adjust the level of the intensity, chromacity, and translucency by moving your restoration in your block. And the block is similar to the shade gradient of the similar natural dentition. And the other product from the Beta company in aesthetic blocks is Beta Block Real Life. Real Life is again a multicolor block, but it contains a three-dimensional structure within the blocks, the nose shape structure, which has a more chromine intensity, and it's similar to the optical characteristics of the dentin, and it's surrounded by a more translucent area, which is similar to the enamel. So you can have a more natural looking restoration with Beta Block Real Life. The other company that offers some telescopic blocks is Serona, and introduced Serect Block and Serect Block polychromatic. The flexure strength of this material is also 120 megapascal, and like Beta blocks, it could be glazed or polished, and it is available in different translucency, translucent, medium translucency, and opaque. Serona also offer aesthetic block with the commercial brand of the Ceramic Block CIN, which is just similar to Real Life. It means that it have a three-dimensional structure within it, and the highly chromatic internal core is molded on the morphology of the dentin, and is surrounded by a more translucent ceramic layer. The flexure strength is again about 120 megapascal, and is indicated for anterior crowns and veneers and for natural looking restoration. The minimum recommended thickness of this material is 0.5. And you can see the CEREC software, which automatically positions the restorative design in the block so that the dentin and enamel shades are precisely matched, and you can also freely move your restoration in the block, so you can adjust the level of the intensity and the translucency just by one click. So if I want to review the indication and contraindication of the aesthetic blocks in general, I have to say that they are indicated for inlays and onlays. We cannot use this material for occlusal veneers or posterior crowns for molars, but we can use them for the crown of the premolars, anterior crown, anterior veneer. We cannot use them for anterior or posterior bridge, or even as a mirror-end bridge. The other material that we're going to talk about is lucite reinforced ceramic. It's a commercial brand IPS Impress Cap from Ivoclar company. This material contains 45% of lucite with a finer particle size of 1 to 5 microns that helps resist meshing damage, and it has a flexure strength about 160 megapascal. Again, it's a one-step material. That means you can mill it, polish it, and sit it without any further heat treatment, or you can put it in the furnace and glaze it. It's available in 3 different translucency: high translucence, Empress Cat HT, low translucence, Empress Cat LT, and polychromatic. The other brand of the lucite reinforced material is Paradigm C from 3M company. And about the indication of the lucite base or lucite reinforced ceramics, I have to say that they are indicated for inlays and onlays. Again, we cannot use this material as a occlusal veneer or posterior molar crowns, but we can use them as a crown of the premolar, anterior crown, and anterior veneer. Talk about the third group of the material, lithium disilicate. Lithium disilicate, which has the famous commercial brand, is IPS Inac CAD from Evocular company. The flexure, reported flexure strength is about 250 to 450 megapascal. And this block is designed for a cherry side monolithic restorative material, and available in different shades, A to D, and it also have bleach shades. But the company says this material as a pre-crystallized or blue state material. I mean that if you go to the market and buy a IPS CAD block, you find it in a blue state or pre-crystallized form. But why this material is in a pre-crystallized form? As I told you, this material have a flexural strength about 300 or 400 megapascal. So hard machining could cause some tool wear and also some surface flaws on the surface of the restoration, which could be long-term detrimental to the in vivo performance of the restoration. So the company overcome these disadvantages by introducing this block or IPS Max CAD blocks in a pre-crystallized or blue state. In pre-crystallized form, the materials contains or the pre-crystallized blocks contains lithium metasilicate and lithium disilicates, and the flexural strength is about 130 megapascals, something similar to the feldspathic blocks. And so you can easily machine it or easily mill it. After milling, you can put your restoration in the furnace at the 850 centigrade for 20 or 25 minutes. And then the crystallization will complete, and all the lithium metasilicate crystals will dissolve, and crystallization will complete. At the same time, the restoration will be glazed. In the complete crystallization format of this material, we have 70% of crystals of approximately 1.5 microns in size, and the strength increased dramatically to the 360 megapascal, and also the color change from the blue state to the chosen color. You can see a mill restoration from the lithium disilicates blocks. In the upper picture, you see that it's in blue state, and even we can have a trying for the restoration of in the pre-crystallized format, because in the crystallization procedure, you have only 2 to 3% shrinkage, and after that, you can put it in the furnace and complete the crystallization, and the color will be changed to the chosen color. Different types of IPS Max CAD are available in the market. The first one is IPS Max CAD HT, or high translucent, which contains fewer crystals with larger size. HT blocks are indicated for highly aesthetic restoration. And we have also IPS Max CAD medium translucent or MT and low translucent LT. LT blocks contains more crystals with a smaller size, and MT is something between the LT and HT, and is indicated whenever you have more brightness than HT blocks and more translucency than LT blocks. We can then use IPS Max CAD medium translucent. And we have also IPS Max CAD MT MO medium opacity, which is indicated only for pores and frameworks, and it's better to have a layering on them in order to have a more aesthetic restoration. We also have IPS Emacs CAD Impulse, which is available in different values and opals. Value belongs for lifelike worthless value plan, and opal belongs for highly aesthetic minimal invasive veneers with a minimum thickness of 0.3 millimeter. We have another form of the IPS Emacs CAD blocks with a hole inside it. If you see in the upper picture, we can find a hole just inside the block. And these blocks, which we named it as a meso blocks, are designed for implant retained plants, which are designed and milled in cherry site and with milling machine. So they are indicated for hybrid abutment and hybrid abutment plants. Besides the good performance of the lithium disilicate, but the evolution of the dental materials attempts to overcome the to suppress the disadvantages of this material by introducing zirconia reinforced lithium silicate. Zirconia reinforced lithium silicates and this new glass ceramics were designed to contain lithium silicate as the main crystalline phase in a vitreous matrix reinforced with zirconium dioxide crystals by 10%. When this material goes through the crystallization process, the nucleated of lithium silicate crystals achieve a mean size of 0.5 to 1 micron, that is up to 6 times smaller than that of we told about the lithium disilicate crystal. In lithium disilicate, the formation of a smaller and finer crystal phase occurs due to the presence of the zirconia particles in the material, and which act as an additive influencing the crystallization by hindering the crystal growth. So we have a smaller crystal in zirconia reinforced lithium silicate comparing to the lithium disilicate materials. And microstructure which contains smaller crystals guarantees the material mechanical properties similar to those observed to the lithium disilicate ceramics, and in addition we have good optical properties, easily milling in CAD machine, and also good surface finishing. And a particular advantage of the lithium silicate ceramics over the lithium disilicate material is the superior polishability of this material due to the smaller crystalline size in the microstructure. Two available commercial brands from the zirconia reinforced lithium silicate material, ZLS material, is Supremity from Vito company and Celtradu from Sirona. Supremity is offered in a pre-crystallized form, as you see in the picture. It has a opal color, and when you put it in the furnace for completing the crystallization, the color also changes to the chosen color. But Celtradu is offered in the fully crystallized form, and so you can put it in the furnace or not. It's optional. For Celtradu, it's available in two shades of low translucency and high translucency, and as I told, you can use it as a one-step material. I mean that you do only polishing. In this case, you will have a fluctuation about 200 megapascals. But if you put it in the furnace and glaze it, the fluctuations increase into the 370 megapascals. And the advantage of Celtradu over the Supremity is that it's more time saving, because putting in the furnace is not essential and it's optional steps. You can put not in the furnace and you can save your time. And Supremity, as I told, is launched in a pre-crystallized form, and the flexor strength in the pre-crystallized format is about 180, and then we complete the crystallization, the strength will increased to 480 megapascal. A marked difference between sulfur-do and supremacy is about the size of lithium disilicate part, which appears to have grown larger in the sulfur-do up to 1 micron in the length than the supremacy. And in this slide, we can find the indication and thickness of the supremacy. They are indicated for inlays, onlays, partial crowns, veneers, and crowns and implants. And the minimum recommended thickness for the anterior crowns is 1.5, and for veneers is 0.7. And finally, the last group of the material was polymer infiltrated ceramic network. As I told, we know this material as a hybrid ceramic, and the commercial brand is Enamic. Enamic contains ceramic for 86% and polymer for 4%. So it combines the best properties of ceramic and composite materials. We have both a ceramic network and polymer network, which are interconnected to each other, and so they form the hybrid ceramic material. The penetrating strength of the Enamic is about 2,100 megapascal. We just do polishing for this material. We cannot put it in the furnace because it has a polymer and it's available in different sizes and shapes. The indication of this material is for minimally invasive reconstruction in the cases with limited space available, crowns, onlays, inlays, veneer, occlusal top table, and anterior and posterior implant supported crown. Different translucencies available for Enamic. And about the advantages of this material is that presenting an elastic modulus that is approximately about 50% lower compared to feldspathic ceramics, so we can easily mill it and adjust it, and also we can easily repair this material by composite resins, and lower elastic modulus and higher damage tolerance. And the other group in the hybrid ceramic is the resin nanoceramic, and with the commercial brand of the Lava Ultimate from 3M company. It contains 80% of the ceramic and 20% of the polymer. Again, we just do polishing for this material. And but there is a big difference in the pre-treatment of these two materials. For Lava Ultimate, we cannot etch these materials, and no etching is needed. We just do sandblasting, applying the silane, and using a self-adhesive resin. While for Enamic, we do etching for 60 seconds with hydrofluoric acid, and then applying silane, bonding, and then applying the cements. I hope you have enjoyed this lecture, and this lecture helps you to make decision regarding choosing the materials easier.
Thank you so much, Dr. Hassanzadeh. It was very comprehensive, very complete, and I'm sure that our audiences have enjoyed it. One point I want to say that Lava Ultimate, that it what's they say about it? Your former slide, can you show it?
Yeah.
Yes. The other one, resin nanoceramics. I think they are composites. They are not ceramics, although they have a lot of ceramic fillers. So they have different treatments. You see, the Enamic is like the ceramics, but Lava Ultimate is not like the ceramic. It is not treated like the ceramics. It is treated like the composites. So I think it is actually a composite, not a ceramic, but it has a lot of ceramic fillers. That's what I always say, although I know in the articles it is mentioned under the name of ceramics. I know that. Thank you so much, Dr. Hassanzadeh. If you want, if Dr. Sadehpour have anything to add?
No, thank you so much. What's your idea about, do you think it's mainly composite or basically it's a part of ceramics?
I not have your voice. I cannot hear you.
Can you hear me?
No, you can't hear us.
Do you hear me?
Speak louder. I would be.
Yeah, regarding the point, Lava Ultimate, do you think it's basically composite and resin based or mostly ceramic?
No, the difference of the Lava Ultimate and the Dynamic is regarding the how the ceramics forms in the blocks. For the Dynamic, we have a network of the ceramics, but for the Lava Ultimate, we have ceramics as a filler. So because of this, we cannot etch it because we do not have a network of the ceramic. We cannot etch it, and just the ceramic is as a filler in this material. You know, putting it under the name of the ceramic or composite, I don't know which is better, but the most important clinical point that we can get from this is that we cannot etch this material because we do not have a ceramic network in this material, and the ceramics, 80% of the ceramic which is present in this material is just like a filler in this material.
Yeah, I think so.
And
I agree.
for finishing, it's written here just polishing, right?
Yeah,
Basically.
both dynamic and lava, we cannot put them in the furnace for heat treatment because both of them contains polymers. We just do polishing for both of them.
Interesting. Thank you.
Thank you so much, Dr. Hassanzadeh. I hope you have a good day from now on, and we hope to see you again. On
Thank
our,
you so much for this congress.
You're welcome. Now we go to our other lecturer, Dr. Atri. Dr. Sadapur going to introduce her
Sure.
to us.
Sure. Dr. Atri. All right. Which camera? This one? All right. All right. Good morning, everybody. Dr. Atri, she's assistant professor of advanced prosthodontics in Tehran University School of Dentistry. Her topic is digital wax-up and mock-up. Is she on? Yes, she's on. All right, Dr. Atri, please move on with your topic. Welcome.
As you know, that a mock-up is a very important step in digital smile design and in the complicated cases. When you have complex cases, you have to do wax up, and sometimes you have to do have the mock-up inside the patient's mouth. So, Dr. Atri, the screen is yours. Of course, good morning again.
Thank you. Good morning. Hi, everyone. Thank you, Dr. Farid, Dr. Sadapur. It's my honor to be here with you. I wanted to speak about digital wax-up and mock-up as Dr. Farid told. It's really important steps in aesthetic treatments. The purpose of aesthetic treatment is to establish new smiles with minimally invasive approaches. We want to provide a smile with maximum natural effect under restoration, and besides the beauty, we want to restore the mastication and phonetics. And all in all, we want to provide better quality of life for our patients. What is different nowadays from past? Nowadays, the patient's demand is really high, and when they come to our office, they have lots of information. They Google a lot, they search in Instagram, and they know a lot. And the treatments nowadays should be customized, and we should consider individual psychological characteristics of each patient before treatment. For example, if our patient is a boss of a company, the treatment plan is different when she or he is an actress or hairdresser. And if we ignore these important points, it leads to statistically dissatisfaction of patient. And as you know, to make it unhappy patient, happy again is really difficult. So what I believe is that the diagnostic laxative is a must, is a requirement before any aesthetic procedure. Actually, it's a tool to evaluate the treatment plan for dentists and technicians, and we can show the result to the patient. It's important to correctly diagnose teeth proportions before any irreversible restorative dental procedure. And it's really a helpful steps in aesthetic treatments. In this slide, you can see 4 different clinical scenarios. I don't know if you can see the pointer. Okay. In this case, all of these patients come to office with the same chip complaint. They want to get aesthetic treatment, but they are totally different. In this case, we have a large diastema, a rotation in lateral incisor. The patient is deep-wide, and from the teeth, we guess that she or he is young. In this slide, we see a mixed dentition, some deciduous teeth, semi-erupted permanent teeth, and there is a trauma to anterior teeth. In this slide, we can see some old stained fillings that the patient is unhappy with the appearance. And in this slide, which we guess that the patient is old, we have gingival recession, lack of papillary, and all these patients come with same chip complaint that they seem to have a more beautiful smile. But we should plan for it. The first step for planning is getting impression. For impression making, it is recommended to use accurate material. For example, additional silicone with two consistency, the putty in tray and the light body injected in the surface of the teeth, and we can get a really accurate impression. And also, we can go for digital method, means intraoral scanning by scanners, and we have the pre-op scan of patient in the software. So where to meet different ideas? As you know, our definition for aesthetic most of the time is different from our definitions of aesthetic of our patients. And we should make a consensus between our ideas. So we want to plan in a academic and logical steps. The first step for planning is dental photography. As you know, dental photography is very important to have pre-op documents and to design according to aesthetic principles. We need 6 pre-op photos, as you can see here: facial frontal with teeth apart, facial frontal smiling with teeth apart, facial profile at first, facial profile at a smile, the occlusal view of the jaw without mirror, and the last one is 12 ocular view smile for evaluation of the midline and also the protrusion of teeth. And besides the photos, we need some videos. The first video is interview video, means casual video from interview with social distancing. The second one is close-up video of 1/3 of lower face when we ask patient to come, smile, and speak to evaluate the phonetics. The third video is a functional movement of jaws, and the fourth one is structural occlusal video. And with these pre-ops, we go for plan. We should know that there is some important principles. First of all, from facial view, we should know about 2 important difference lines. The first one is horizontal reference line, which is a line that passes from the papilla of the eyes, and this line should be parallel with the incisal edge of the anterior teeth, and it's better to be parallel with the cervical margin of anterior teeth. The second reference line is vertical, which is perpendicular to the horizontal reference line, and it passes from the midline of the face, and it should be aligned with the midline of the teeth. In more detailed view, we should evaluate the smiling close-up view. We should evaluate the visibility of teeth. As you know, in young patients, we see more teeth, and with increasing the age, the tooth show is decreasing. The second item is a smile curve. A smile curve is a curve that, in smiling, the lower lip make a nice curve that is pleasant for us to have a parallel line with the incisional edge of teeth, as you can see here. And the third item is buccal corridor, means the space between the teeth and the corner of the lip. If it is so huge, it's not pleasant, as it's a black triangle, and it's not nice. And if we omit the buccal corridor, it's so artificial and not natural. And in more detailed view from the inside the mouth, we should check the midline, that it's better for upper and lower teeth to be aligned. We should about teeth axis. Most of them are parallel, a little convergent to the midline. And gingival zenith is so important, as you can see here. The highest point of gingiva from the central incisor to the canine go distally. And the third item is incisal embouchure. As you can see in the slide, from the central to the posterior teeth, the size of incisal embouchure is increasing. Besides these factors, we should consider age and sex of our patients. In young patients, we have larger embouchures and more vital smile, but with increasing the age, the embouchure size is decreased. And as you know, in women, we have more soft teeth and round line angles, and in men, we have bold teeth and sharp line angles. And we should consider these items for treatment planning. And at final point, we should make a harmony without exact symmetry. You can see here, it's a natural teeth, really pleasant and are in harmony, but they are not exactly symmetrical. When we compare the teeth in detail, we see that they have some different items. And we should consider these points in our wax up and planning too. Digital smile design is a method for smile designing, and it should involve some things that I will mention. But the principle is same than the conventional way. In this digital smile design, we have participation of patients on the designing process, and it makes the patient feel more confident. The second point is that smile designing by digital methods lead to customization of smile design as per individual needs and desires, with the complements of the morphopsychological characteristics of the patients. And as I told, it increased their confidence in the process, and it results in better acceptance of the anticipated treatment. In this slide, you can see some brands of digital smile design softwares. Some of them are really simple, like Photoshop, and some of them are professional, like Visa, G Smile, and all of these softwares are used to make a smile with principles. And in all digital smile designing, we should consider an incisal plan, tooth axis, gingival zenith, papilla, incisal embrasures, tooth shape, proportions, and harmony. In this slide, we can see two-dimensional smile design. In this protocol, we use a photo of the patient, facial view, and keys. And in the software, we can plan to have keys that are more in harmony and with the checking the smile care. After that, we transfer the planning to our cast, and we can use the planning of software in conventional method in our Alexa, and so we can proceed in conventional method. As you can see, the result is amazing. But 3D smile design or three-dimensional is more professional. We need some photos. As you can see here, the facial photo at rest and at the smiling, and the photo of lower one-third of the face at rest and during the smiling. And also, we should have a model of this. We can get a conventional impression and scan the cast, or directly scan intraoral condition, and then on the model, we can plan teeth to more beautiful proportions and pleasant view. And in the software, we can check these teeth on the face of the patient and then close up the teeth in rest and smiling. And it's really helpful and it's really predictable. Here we have a short movie that shows the smile planning in Exocad software. Okay, sorry for being late. First of all, we should select two same points in our cast and this in the mouth of our patient. As you can see here, it's about tip of the canines. And after that, we should mark the mouth and the tooth show of the patient. And we superimpose the cast on the facial photo of the patient. After that, we should mark the papilla of the patient and draw the reference lines, means horizontal and vertical reference lines. And according to library of the software, we choose a special model of these to superimpose on the patient mouth. And as you can see here, we can change the teeth as desires in 3 dimensions, from the occlusal view, from the lateral view, and from the frontal view. And we can repeatedly check the changes in the mouth situation and also the facial view of the patient. As you can see here. And after that, we should perform some adjustment in the model. For example, to adjust the marginal level of the teeth and adjust the occlusion. Check about the embrasures, check about the papilla. And after finishing, we can export this model to have the cast printed. And it's a digital method. It's really nice. It's not same as conventional method that we waxed up. It's really more simpler and more accurate. And we can go on with this design. The second step of aesthetic treatment is mock-up. As you know, mock-up is a diagnostic procedure. Imagine mock-up like a smile simulation, means happening directly over patient teeth, and we can check about the changes. Something like a test smile. It changes temporarily the shape and color of teeth in order to check the changes and to evaluate the result before starting the procedure. It actually is used in the first steps of a smile design procedure. In this slide, you can see that the pro-op situation of the patient, born teeth and not pleasant curve of a smile, and we did the conventional wax up and we did the conventional mock-up here, and it's really nice to evaluate the result before starting the procedure. The purpose of mock-up is that it's a really useful communication tool for patients and the dentist, and we can simulate the final outcome. It results in a temporary change, and we can evaluate it according to patient's desires and demands, and it can be repeated as many times as the patient is satisfied with it. It helps create trust between the patient and the dentist, and also dentists can evaluate the patient desires and changes during the mock-up. You can see here a pre-op position and a mock-up. And usually the resulting changes are significant, and our patients need time to understand and evaluate the results, and we can get some photos, and in the photographs we can discuss with our patient if she or he likes it or not, or how we can change it to be more present. Sometimes when the mock-up has the right thickness, we can give it to our patient to go home and ask about the opinion of the family and friends. But we should know that it's not practical in all cases, and we have some limitations. The most important case is the case of crowding. As you know, in a case of crowding, we should prep the teeth and then we can do the smile design. And we cannot do mock-up without any preparation on the teeth. So we can evaluate the result in the provisional stage after preparation of the teeth. As you can see here, a smile crowding is prepared, and in provisional stage we can decide about the changes. And sometimes in the case that patient is not happy with the result and the changes do not satisfy our patient's idea, we plan to do nothing or refer the patient to orthodontic treatment. And it's really good to make decision at the first part of the treatment. So we are going to see the procedure. It's the conventional mock-up. You see the wax up here. First step is to make a silicone index. It's better to use additional silicone for making index. First the putty, and after that we should reline it with a light body for more details. And when our silicone index is ready, we should remove the margins until the level of the gingiva, and after that we cut the interdental sections to make a escapeway for additional material. And then it's better to use temporary material in injectable form inside the silicone. It's really nice because it reduces the bubble formation. And then we put the index in the patient mouse according to midline, and after the setting, we remove it. And we can evaluate the result in this step. The material in this slide was acrylic material, but we can use composite material that are more color stable. So for this purpose, we need the clear silicone. As you can see here, it's a silicone index with clear material, and we can inject the composite material inside it and use light hue to set the material. And as you can see here, the result is more pleasant, and you can polish it, and it is color stable, and we can deliver it to patient for longer time. Okay, let's start about digital methods. In this slide, you can see that we did digital smile designing in software, and we have printed cast, and we can use the printed cast to make silicone index. And also we can have vacuum shells on printed cast, as you can see here, and this vacuum shells helps us to use composite material. And in this slide, you can see it is the digital smile design in software, it is the printed cast, and it is the vacuum shell out of it. We inject the composite material inside the vacuum shell and put into the patient mouse, and we can light cure it and remove the excess, and we can see the result that is really nice. Also, we can go further and have more digitalized method of mockup. When we plan to have a smile design in the software, we can plan to have an index on it in the software, and just we export the index and print the index. As you can see here, it's no need to print the cast, but we can just print the index and use it as a key for transferring the smile design to patient mouse. You can see here the mockup with acrylic material. And also we can print the index with clear material. You can see here it's clear resin for printing, and with this kind of material we can use composite material in mockup. And if we want to go further, we can plan to have aesthetic smile design, and then we can have just the mockup mill. Means we export the mockup and mill to CAD/CAM milling machine, and we can use this milling on the piece and evaluate the result. And if we want to go further, we can do our preparation on this mockup on the piece of the patient. And it's a benefits that we can have 3 or more different model of designing, and we have milling on them and check in the patient mouse. And in this case, we can see the milling mockup in 2 half sections. And if we want to go further, we can have the mockup printed. In this case, the patient was unhappy with these 2 central incisors, and we plan 3 different model of central and print them, and we can evaluate all of these models just in 1 session. And we can decide which one is better for our patients. Okay, but we should mention our limitations. As the diagnosis and treatment plan in digital methods depends on photographic and video documentation, if we have any inaccuracy in them, it may distort the reference, and it may result in an inaccurate diagnosis and plan. The second limitation is that 3D digital workflow needs softwares, intraoral scanners, printers, milling machine, and it's really expensive. The third drawback is that the training and handling for this software are necessary, and it increases the cost and time of our procedures. And in this table, you can see the comparison of digital and conventional methods. As you can see here, the harmony, predictability, and satisfaction of patient is same in both methods, but accuracy and time and symmetry is better in digital methods. And for the last slide, let's see this nice digital planning. It's the pre-op situation of the patient, it's the printed cast and the mock-up. The preparation was performed on the mock-up, and it's the final preparation of laminates. And after scanning, we have a smile designing in software for final restoration. And here is the result. As you can see, it's really natural, pleasant, and the patient is happy. Hope to be successful. If you have any question, I'm here, and you can send me email or message me in Instagram. And thank you, Dr. Farid, Dr. Sadafur, for your hospitality.
Thank you so much for a very nice and informative presentation. Dr. Ati, may I ask a question? Like, did you say the mock-up index was silicone, from silicone, 3D printed silicone?
Yes, it's not silicone. It's a rigid material. It's a resin, but we can just print the index, like here. We design an index over our smile design, and then we print just the index, not the cast. And we use this printed index for mock-up.
Yeah, so
Out of ordinary material like here, or clear material. And the clear material is advantageous because we can use composites.
yeah, and I think for this kind of mock-up inside the mouth with such multiple number of teeth, it is better to use composites as for a mock-up rather than any other material that makes heat or something like acrylic resins or so on. Yeah. Thank you. Dr. Sadaf, do you have any question?
Yeah, one question. Thank you so much for the wonderful presentation. Yes, what topic recently, so I'm sure.
Sorry, I can't hear.
Yeah.
Louder.
Yeah, here.
Sorry, my laptop is on mute, so I have to ask from this time. This is a hot topic. DST recently is a hot topic. So thank you for this wonderful presentation. I have one short question. Since in the market every day we have a new material, for the mock-up, we do have PMMA material and composite-based material. Which one do you recommend for us? Which one is more practical and user-friendly?
It depends. If you want just to mock up in a session and after that start preparation, it's better to use acrylic material because you can remove it easily and you need no color stability. But if you want to deliver mock-up to the patient and do preparation on the next session, it's better to use composite material, which is more perishable and is color stable, and it's more stronger. It's stronger. The strength of composite material is higher than acrylic material. And in this situation, we decide to use composite material. But we should consider that composite material is more expensive, and we need, for example, clear index for them. And the clear index is exactly more expensive, and the charge of the patient will be raising.
Right, and in the market of Iran, since we have a limitation, which brand do you recommend us? What do you use recently?
It's lots of brands. We have some clear silicone. I think the company of Bisco has it. And also for composite material, we have some of them. I'm not about the exact name of the material, but we can provide it from the physical company too.
Perfect. Thank you so much. Yeah, I have experience with Integrity from Dentsply. They provided recently is a composite base. As you said, it's perfect for as a long-lasting temporary mock-up, but you know, every day we have a new material, so there's always a new option. Thank you so much for a wonderful presentation. Hopefully see you soon in the next meeting.
Thank you. Goodbye.
All right, we have the next lecturer, Dr. Mustafavi. She's Associate Professor of Prosthodontics Department, and she's Head of Research Committee of the Prosthodontics Groups. All right, Dr. Mustafavi, her topic is regarding tooth preparation for CAD/CAM restorations. So if you hear us, please move on. Dr. Mustafavi, are you on? Is she on?
Perhaps they are
There is
changing
a delay. All right.
changing the slides. As you know, for the tooth preparation is the important part by the dentist, and we all should know the principles of preparation. We have a conventional principle and some modification for digital dentistry, as Dr. Mustafavi is going to tell us about it.
Great. Welcome, Dr. Mustafavi.
Hello, you have my voice.
Yeah, we hear you.
Good morning. Can I start the lecture now?
A nice picture from dental school.
Can I start now?
Yeah, please.
Thank you.
You're welcome.
Hello, everyone. My dear colleagues, friends, and all the participants in this lecture. Good morning. I am Dr. Mustafavi, and I hope you to be safe and healthy. And the title that I'm going to speak about today is the principle of preparation for CAD/CAM restorations. What do you think? Do you think that is really different from the conventional method? So let's take a deeper look to the subject and its influential factors. When a patient like this case come to us to rehabilitate their dentition, so we should consider, we should picture the final result through the VAXA procedure, either in the digital format or the conventional one. In this regard, we can prepare the teeth in such a way to receive the final restoration to accommodate the form, function, phonetic, and aesthetic. As you all know, the key to a successful restoration is the good preparation. I know that all of us are familiar with these basic preparation principles, thanks to Dr. Schlimberg. And in our daily practice, we consider all of them. And furthermore, we know the affecting factors which influences the previous preparation principles. Maybe you have seen the principles of the preparations, which are categorized in three aspects. Biologic aspect, which is related to the health of the oral tissues. Mechanical aspect, which is related to the integrity and durability of the restorations, and aesthetic aspect, which affect the appearance of the patient. So now I ask my question once more. Do you think that these considerations would be changed if we apply the digital workflow? As a matter of fact, optical scanning demonstrates accuracy which is similar to or possibly an improvement upon the traditional ones. Okay, but in particular, the dentist receive immediate feedback, I mean, about the taper, about the marginal integrity, interocclusal distances, and undercuts, and it avoids the additional appointments. But actually, the principles are the same. They are not different between the conventional and the digital workflow. However, the CAD/CAM from preparation designs must accommodate some considerations like scanning and milling. According to the literature, general dentists have some difficulty in fulfilling the principles for preparation for CAD/CAM restorations. And this difficulty is the most in the parts related to finish line design and total occlusal convergences. Studies have shown that the main reason for failure of ceramic restoration is inadequate reduction. In the case of inadequate reduction, we don't have the adequate thickness of the ceramic restoration, so the fracture will happen. And in this case, we don't have the optimum aesthetic tool because of inadequate thicknesses. Therefore, this question arises: can the restoration failure be avoided by modified preparation design? Yes, definitely. Rounded cavity shapes, which especially with that classical bosses and step preparation, would reduce the physical stresses and therefore increase the strength of the restoration. There exist two factors which have the key role in preparation design. One of them is selected material. As you know, each of them has its own certain thicknesses, and the diagnostic VAXA, which tells us the available space that we can use them for the restoration. If we apply digital workflow, we encounter some limitations. Some finish lines, for example, which are not distinct, like feather edge margins, are not recorded with intraoral scanners, as well as sharp line angles. So before going through the principles, let's become familiar with these kind of limitations. As you can see in this picture, all of the prosthodontic restorations have two inner and outer surfaces, and our preparation affects the inner surface of the restoration directly. Yeah, for example, in CEREC milling machine, there exists these milling burrs. As you can see, the step burr is responsible for forming the integral surface, I mean the fitting surface of the restoration, and this round and cylindrical burr is responsible for forming the outer surface. As you can see, according to the length of the burr, we can't use it for restorations and for abutments with a height more than 10.5 millimeter, which is rare in our daily practice. Sorry, I have a question. Because of this screen share, I'm missing some of my slides. Can you delete it? Sorry for interrupting. Okay, this burr, I mean this step burr, only can mill 0-degree surfaces, which are less than 4 millimeter in height. And for higher surfaces, we should consider at least 3-degree tapering in the surfaces. It is because of the shape of this burr. If you draw a line from the bottom of this burr to the top of this burr, the inclination of the line would be 3 degrees, as you can see in the picture. But for exception situations, the system proposed a specific mode for you to in order in order to fulfill the preparation. We spoke about the height, and what about the diameter? As you know, we haven't much problem in the posterior part because of the dimension of the posterior part. But as we approach the anterior part, the size of the anterior teeth is smaller, are smaller than the posterior ones. So we have some limitations, and we should consider the dimension of the milling burr. If the incisal diameter of the teeth after preparation is less than the diameter of the milling burr, it would be a problem for you. Let me give you a point about the zirconia restoration. We haven't, this concern is not, is faded for zirconia restoration somehow, and we will reach to the reason in some slides later. If you want to predict the thickness of the incisal part of your preparation, you can measure it at the junction of the incisal of the teeth, and it depends on part of your preparation should be maintained wide and flat and as wide as possible, but not jeopardizing its height because it affects the retention and resistance form of your preparation, of course. In this slide, I'm speaking about the phrase drill compensation. What is drill compensation? It is a procedure in which the intaglio surface of the restoration is designed to be compatible with the diameter of your milling burr, and some factors influences on it, like tool shape, material substrate, tool diameter. As you can see in this picture at the bottom of this slide, you can see the appropriate shape of the fitting surface of the restoration in the middle of the picture, but the CAD software has enlarged it to accommodate the diameter of the milling burr, as you can see on the right side of the picture. Therefore, we have some disadvantages consequence to drill compensation. For example, we have thinner restoration thicknesses, excess cement space, so the final restoration would be weaker. Therefore, it is better to avoid sharp angles in the preparation, especially when we consider grooves and boxes in our design, in our preparation design. The angles should be rounded to avoid overmilling. So we turn back to this question. Why the effect of drill compensation on zirconia restoration are barely visible? As you know, zirconia blocks are designed in semi-sintered, I mean the partially sintered phase. It means that they are somehow 25 to 30% bulkier. And this bulkier format would accommodate the dimension of the milling burr. So this concern would be faded for zirconia restorations. It is obvious, as you can see in this slide, that using rounded and milling tools can diminish the effect of drill compensation and overmilling. Since different milling machines present different sizes of milling burrs to the market, this question can be arises that why we don't use the smaller ones. They are more intricate, okay? So It is obvious that using smaller milling tools would provide more intricate preparation features and minimize overmilling. But on the other hand, your milling time would be increases and the milling tool loses its cutting efficiency and consequently requires more frequent replacement over the time. Okay, let's see and continue to slide the guidelines about the occlusal reduction. As you know, every material needs its own certain thicknesses. So we should follow the instructions and you can check it with different ways. For example, Masing burrs are appropriate way to check this reduction. You can use silicone indexes, you can use occlusal waxes, flexitap, or these kind of plastic instruments. Satisada et al. Has demonstrated that when occlusal interpascal angulation, which is named ICA, would be increased from 100 degrees to 118, it has no significant effect on the resistance form and also the marginal integrity, but due to decreasing the surface area, the retention form would be decreased. About the outpunch height, all of us know that we should consider the 3 millimeter for the ancestral and 3 molars for the height and at least 4 millimeter for the molars. But the most important point that you should consider is the ratio between the height and the base. And it is proposed to consider 0.4 for this ratio at least. Many studies have shown that it is appropriate to provide total occlusal convergence between 6 to 10 degrees to allow terrain the ceramic restorations without the risk of fracture. Besides, the intraocular scanners can scan the details more appropriately in axial inclination more than 4 degrees. As you can see, the realistic clinical total occlusal convergence, I mean that the one we perform it in our clinical practice is ranged between 10 to 20 degrees compared to ideal one, which is 2 to 7 degrees. Major et al. Have shown that when the total occlusal convergences would be close to 0 degrees, the accuracy of the impression and also the stone cast would be decreased significantly. About the line angles, you should round all of them in order to decrease the stresses. But remember that maintaining line angles between buccal surfaces and proximal ones would increase their resistance form. Okay, we should have finish line in the chamfer or shoulder format with drawn internal angles for the CAD/CAM preparation, and they should be distinct enough to be recorded by the scanners. You can use these self-limiting burrs in order to avoid gutter margins. And remember, the spot margins can't be recorded adequately with the scanners, and it will result in open margin. It is obvious that supergingival margins and epigingival margins are better. Margins should be smooth and continuous. Thin margins, for example, bevels or feathers, would be fractured during the milling processes. Maybe your technician in the design phase would modify the thickness of the margin by adding some extra thickness on the outer surface of the margin, but as you know, it would result in overing of the restoration and periodontal problems. About the sharp angles, as we discussed it earlier in the drill compensation part, these sharp angles would be result in overmilling and open margins. So it is better to avoid them by rounding the transitional edge, angles, and corners in our preparation designs. Okay. Finishing is of great importance after the preparation, and we should use the same size and same shape of the final burst in our finishing procedure in order to have smooth surfaces. As you all know, the difference is totally about the grid sizes. About the undercuts, they should be avoided or blocking out. As you know, undercuts are considered as a problem in conventional format because they result in distortion of the impression material when we want to take the impression out of the mouth of the patient. But it's not a limitation for digital platform because you can rotate the scanner everywhere and you can record the undercuts, and in the design process, if you have minor undercuts, you can block it out or change the path of insertion. But if the undercuts are in the vicinity of the outer surface of the restoration, and blocking out of the undercut should result in open margin, which is a defect. About occlusal contacts, be aware to put them away from the MIP. To fulfill this phase, you can mark them with articulating paper before starting the treatment, and after that, according to these marks, you can have your own preparation design. Okay, in this slide, you can see a snapshot of the guidelines related to preparation of posterior teeth, and we have spoken about it in the previous slides. The angles, the tapers, and it is also for the anterior teeth, and I'm not going to repeat it again. The manufacturers propose some instructions and some guidelines about the preparations for each material based on their physical properties. So it is very important to follow the instruction, and it shows the importance of the selecting material before starting your preparation, because there exist some hints related to that special material and about the dimensions, and you should follow. As well, for the partial restorations and the CAD/CAM preparation, we can use these guidelines as well. I mean, for the onlay restorations and for inlay restorations. It's the same for the veneers. We should consider the enough thickness for the material and the finish lines. After a while of practicing, each of us would consider a set of work for ourselves which we are more comfortable with them in preparing the teeth. Also, the manufacturer proposed some bare sets for CAD/CAM preparation, which facilitate the procedure, and you can use them. For example, round and tapered bread are very useful in preparation for CAD/CAM design. And as you can see, this occlusal contour bread is very useful for rounding the sharp angles and forming the occlusal surface. At the end, I want to propose you to remind these tips when you are going to design your preparation for CAD/CAM. First of all, smooth tapered walls, because intraoral scanners record the details of smooth surfaces more accurately, and ceramic restoration needs to have passive feet. We should have sharp, well-defined margins to be recorded by the scanners, rounded internal line angles to reduce the stresses. You should be careful about exit angles and margins. Remember about the undercuts. And finally, adequate tooth reduction, which results in good strength and aesthetic. If I want to see you the roadmap in this platform, I can see you you can have a look to this slide. First of all, you should evaluate the condition of your patient. After that, you should select the material, and then you should coordinate with your lab about the material and the milling machine. And you should start your preparation according to the guidelines with an appropriate armamentarium. After that, you can have your scan. And finally, you should check the design and check the preview of your preparation. Finally, I wanted to share this nice poem, which is belongs to Molana, and unfortunately I didn't find the English version, but I can read the impression format. اگه چون ماهی نباشد توی روز پایان آب حتما ماهی بود که فرصت پایان کند. I'm really thankful for your attention, and this is my contact information, my email and WhatsApp contact. You can make connection and ask questions from me through these links. Thank you and have a nice day.
Thank you so much, Dr. Mostafavi, and I think you have to update your profile because you are now associate professor. Can you hear me? Do you have my voice?
Sorry, now I have you.
In the last slide, you have to update your information. You are now associate professor. It is written there, assistant professor. So.
Thankful from you to provide this time for us to have communication in this platform and share ideas from this platform.
We have the honor to have you up with us. It was very nice and very precise. And I have a question with the permission of Dr. Sadapur before. So I want to say something. We always say the finish lines should be round, but I think even if occlusal surface, the angles of the occlusal surface between the occlusal and the axial walls should be round too, because if they are not round, the birds the former birds that I know were round during milling, and if we reduce the tooth with line angles, not very sharp line angles, or even this kind of line angle, they make it round, and so the fitness of the crown over the prepared tooth will not be as good as it must be. There will be more gaps. I think you didn't hear me, Dr. Mosafawi. Did you hear me?
Yes, I hear you.
Yeah. And
I don't know if you have this slide. No, you don't have it.
yeah, as you see on the right side, and their red circle.
You are completely right. And I don't know if you can see this slide. As you can see in this picture,
Yeah.
it's need to avoid the sharp angles even in the occlusal surface. And as I presented, according to one article, they are working on even on the angle of the interocclusal angles of the cut, and it has been proposed to bond all the sharp angles, even the occlusal surface, because if you don't do that, the dual compensation will be occurred, and we would have overmilling and weakening of the restoration will happen.
Yeah, I mean that this slide, the left picture, and the one that has reduced more, the thickness of the material is good now, but the line angles are, I think, should be like the right slide at the red circle, should be like that, because the milling machine do something like the red. It means that it mills like the red circle, not like the slide on the left side. That's, I think. What do you think, Dr. Sadafur?
Yeah, that's why we came up with the modified shoulder. We don't need any sharp angle in the axiogingival line or axio-occlusal line, which all of them should be rounded. So that's the concept of modified shoulder, or what Dr. Mostafawi mentioned in the whole preparation scenario. So
it was very, very, very good, Dr. Mostafawi.
and it's very useful for everybody.
Yeah, we enjoyed it a lot. Thank you so much.
And can I?
If other participants have any other questions, I'm here to answer. By the way,
We ask question instead of you always
So
ask
one
question.
small question regarding the drills that you showed us, the depth drill.
your voice is.
You hear me? Can you hear me? The slides that you showed us, the depth drill, there was a kind of drill we can measure the depth of the reduction, and you had it on the occlusal surface. Do you have it in the axial wall as well or not?
About it, a step drill?
Depth cut.
Depth drill, the drills that you could measure the occlusal reduction.
Oh, you mean the Mazinger burrs? Yes, yes. There exist some burrs, and they're useful to. I don't know whether I can find a slide or two. You can measure the occlusal reduction with them. They are so useful, but I haven't used them. I just see them in the slides, and they're so useful. We use the other ways to check our occlusal reduction, but the Mazinger burrs are very useful, and you can save your time with these burrs to check it out.
Interesting. Thank you so much.
Thank you so much from you. Have a nice day.
You too, and goodbye for you. Our next presenter is Dr. Qudsi. She summarizes all we have learned about today, about the materials, about the how to prepare the tooth in his presentation of laminate veneers. And yeah, here is Dr. Qudsi, and Dr. Sadaqur will introduce her. Thank you so much.
All right. Good morning, Dr. Qudsi. Welcome. Welcome. Dr. the Associate Professor of Prosthodontic Departments in Tehran. She's a member of Prosthodontic Department since almost 12 years ago, and her topic, digital workflow for dental laminate veneers. You have Dr. Qudsi here. Please move on. Thank you. Welcome.
Dr. Qudsi, can you hear us?
Yes.
Okay,
Let me.
Yes, screen is yours, Dr. Qudsi. All ears.
Okay. Hello to everyone. I hope you enjoyed the presentation up to now. First of all, I should thank Dr. Farid for her program and planning this program, and Dr. Sadegpour for his helpful, I don't know, for his helps and everything he made for this presentation and virtual event. It's my I'm Safura Qudsi, a member of Prosthodontic Department, and it's my honor to participate in this virtual event for colleagues and friends, and with you, my dear audience, that I hope we could have a nice presentation and discussion on digital workflow for dental laminate veneers. First of all, I will have a cursory look at ceramic material that was discussed with Dr. Hassanzadeh, I guess, and then I will go for the indication and advantages of laminate veneer. After that, I will present a clinical procedure for making a laminate veneer, and then I will present two case on digital workflow and combination workflow for fabricating the laminate veneers. As you are surely aware and you know, we have different material suggested and introduced, especially for digital workflow. The ceramic material has been introduced especially for aesthetic restorations like laminate veneers. From these, the high glass and low glass material, I mean the glass containing ceramics, are preferred for laminate veneer. Does it mean that we could not use zirconia for laminate veneer? Of course not. We could use zirconia, or even things should be considered. For example, if you decide to use the zirconia, the bondability has been proven to be increased by sandblasting and using a primer. But in low thickness of laminate veneer, the sandblasting of material could of the material. So zirconia is not laminate veneer. And we have lithium silicate and slab cast, steep cast ceramics for laminate veneer. As you can see here, we have two patients treated by two different materials. The upper one has been done by lower one with lithium disilicate
Dear audiences, we have a small problem with the internet connection. So we will continue as soon as the problem is solved. Now, you know that and live programs, these kind of problems could happen. Isn't it?
Yes, sure. Yes, online presentation. Hopefully, with fading the virus, we're gonna get together again in the Congress and symposiums so we can attend in the Congress. We get rid of the online presentations. Now I think she's back.
Online presentation have their own advantages, I think, because you can again and again see the presentation if you miss a part of it. I think.
Right,
And,
right. That's
and
one
we
advantage.
couldn't have such people all gathering perhaps out of Tehran, out of Iran, such a gathering. I think that it has its own
Yeah, that's the
advantages.
beauty of online
Yeah,
presentations.
yeah.
Advantage of the coronavirus.
Yeah, this was,
You learn
it
how to
was,
teach
yeah.
from
Yeah.
long distance.
Of
So,
course, any advantage have some disadvantages with
right.
it. Yeah. So
so I think she's back now.
no, she's not. And okay, and take your time, Dr. Qudsi. It's okay because our participant is going getting more.
So if anybody has question, please write it down for us so we can discuss while Dr. Qudsi is back again.
Yeah, Dr. Sadaqpour, as you know, the laminate veneers are something that recently,
And
yeah, people,
there's much more demand
and
rather than.
And I think the reason could be better ceramics that we have nowadays, like CAD/CAM materials,
Right.
or lithium disilicates, or
Zirconia veneers. We had a chair from feldspathic that Dr. Qudsi mentioned for the latest case, and then we all switched to silicate ceramics and like Emax, and now recently, since 2 years ago, we had zirconia veneers. They're very successful, they are very strong, and during the trying, we have no worry of fracture, so they're very common recently. And I was in US like a couple of months ago, and most of the veneers were made from zirconia. Dr. Qudsi, are you on?
Was it?
Do you hear?
We have two types of zirconia. One of them is very tough, like a steel, and one of them is less tough because it is a cubic zirconia, and mostly we know it for under the name of translucent. Somehow less toughness and less strength. Dr. Qudsi, we still can hear you if and you can participate in the discussion. Oh no, not that. Oh, I'm so sorry. And
It's fine.
we are going to unmute you.
Ask to unmute.
Ask to unmute. Now, say something.
Now I can talk.
So this is we are discussing about zirconia. I didn't hear what you were mentioned about zirconia. What did you say about zirconia? You were talking about it.
I said that. Yeah. I said that zirconia is one of the options for laminate veneer, as it is used by some dentists in our country. And I said it is not contraindicated to use zirconia, but zirconia has some problem with bondability to resin cement and some problem about the aesthetic.
Yeah,
Translucent zirconia is an option for laminate veneer, but the bondability by resin cement is one of the challenge. Sandblasting has been proposed to increase the bonding ability of zirconia, but sandblasting in low thickness of laminate veneer is completely challenging, as it could cause the microfracture, microcrack, and final failure of the material.
yeah. Thank you so much for saying that. Okay. Now it seems that we are going to have the slides, and
Do you have my screen now?
yeah,
Yes, you're on.
yeah, please.
Okay, let's return to the presentation, and I'm so sorry for the problem happened. It is about internet. Okay, I said when we have a patient that needs some laminate veneer, we should select which material is an option for him or her and select the material. One of the factors affect our choice is the stress factors. When, for example, a patient sustained from bruxism or the higher stress situation, we could not go for the material with lower strength like high glass ceramic, feldspathic, and lucite reinforced, since they will sustain up to 120 megapascal. So we prefer to use the material with higher strength, just like lower glass ceramic. For non-vital teeth, the same scenario exists, since the non-vital teeth has lost a part of their structure, especially the roof of pulp chamber. It is possible to increase their strength by material that has enough strength. So the second group is preferred. For discolored teeth, another problem exists. When we have discolored teeth, we should select a material that could cover the discoloration. I mean, for example, a material with higher opacity, like the second group, a material that has a less translucency. So again, the first group is not an option. When we have higher aesthetic demands, we have the reverse scenario. When we have a patient with higher translucency and high aesthetic demand, and we want to imitate her or his teeth color and aesthetic, we prefer to use the first group, the feldspathic and lucite reinforced. So we have different scenario and we have different special characteristic of the patient that help us to select a correct material for each situation to guarantee the durability and aesthetic and the satisfaction of the patient. Another important things that we should consider for selecting the material is method of fabrication. Slurry and powder is a conventional method of ceramic application that is prevalently used for covering the framework, zirconia framework and metal framework. But it can be used for laminate fabrication completely directly on the cast. It is very aesthetically pleasant, but not so strong. Another method that we could benefit from for fabricating our restoration is pressing the ceramic into the mold that is formed by molten wax technique. And a very interesting method that has been introduced for digital workflow are CAD/CAM material fabricating by milling or 3D printing. And they are very useful when we want to go through the digital workflow. Okay, let's go for laminate veneer and know which technique is applicable for fabricating laminate veneer and what are the indication, contraindication, and advantages of this procedure, very prevalent procedure. If you want to fabricate a laminate veneer, we have three different procedures that all could be used for fabrication of restoration. One of them, as was discussed, is feldspathic porcelain. It has been introduced for feldspathic porcelain and lucite reinforced ceramic, that is conventional powder slurry ceramic that provide higher aesthetic but lower strength. Heat pressed ceramic reduce the inaccuracy happen with hand fabricating procedure, and it can be used for lithium disilicate and lucite reinforced ceramic. And CAD/CAM is another technique, very interesting, very acceptable, very precise technique that can be done by all the ceramic they are available now. So all the ceramic has been provided in CAD/CAM mode. What are the indications for laminate veneer? Especially we use the laminate veneer for enable the patient aesthetically and you provide a pleasant appearance. So if the patient has darkened teeth, stained teeth, hypercalcification, misshaping because of peg lateral, for example, or multiple diastema or chipping, we can use laminate veneer. Especially, we can use the laminate veneer for changing the position of teeth, especially if they are lingually positioned. And it is very important, if we could use another conservative and more conservative technique, we prefer to use them. So the orthodontic treatment has a priority compared to laminate veneer. But we
Sorry, it is now it is fixed, I think.
have a screen now.
Yeah.
Let's see some patient treated with according to the indication. This patient referred for the length of her teeth. And her chief complaint was about shortened upper incisor. After gingival leveling with laser, she was not satisfied, and laminate veneer satisfied her by the new appearance. The second patient chief complaint was about the malalignment and discoloration, and you can see the final result. The other patient with the same problem, malalignment and discoloration, and the final result satisfy her and satisfy us, of course. And the patient with discoloration caused by old composite veneer and stains, and the final result. This patient was treated by the indication, according to the indication of laminate veneer, but we have some contraindication for this type of treatment. If we have a patient with insufficient to the structure, I mean enamel, especially on the boundary, we prefer not to use the laminate veneer. Does it mean that we could not bond to dentine? Of course not. We could use dentine for bonding as according to the special material and resin cement introduced for bonding to dentine. But another problem warns us about using a laminate for such a case, and that is the strength of substructure. Dentine could not protect the low thickness laminate and increase the risk of a problem, and the bondability and the durability of bond in enamel is more predictable. When we have excessive interdental spacing, more than 4 millimeters, we prefer not to use laminate veneer, since laminate could cover the interdental spacing up to 4 millimeters, 2 millimeters for each tooth. The labial version could not be treated with laminate veneer, since laminate veneer will increase the thickness, add to the labial contour. And when the patient has poor oral hygiene and caries, we prefer not to use any indirect restoration for the financial problem, and of course for increasing the risk of caries and increase the problem of oral hygiene by adding the marginal discrepancy that could be happen by even CAD/CAM restoration. For a functional habit is not contraindication, but is warning. It is something that you should consider when treated the patient for with laminate veneer. And when severe malposition and crowding exists, we prefer to use orthodontic treatment. So such a patient is not a good candidate for laminate veneers. Let's go for clinical procedure. Before everything, we should decide what should be changed: the color of the tooth, the shape, the position, or surface characteristic. It is very important to know the chief complaint of the patient could be completely different from what we think. So it is very important for a patient searching for aesthetic and has aesthetic demand to determine what she or he wants. And it is strongly suggested to have a primary radiograph or photograph, since the patient who seek for aesthetic is very high demand. So we determine the chief complaint, make the photograph, radiograph as a study model, and then go for preparation. The preparation is necessary to provide enough space for our restorative material, to provide a well-defined insertion path and facilitate the insertion and to hide the preparation margin. Does it mean that we could not have a laminate veneer without preparation, prepless laminate veneer? Of course not. We could have fragments as a prepless laminate veneers, but three things should be considered, should be noticed. One of them is about undercut. When we have a restoration that is fabricated by indirect method, we should eliminate any undercut. The second one is about the preparation margin, so that the technician could read and could fabricate our restoration up to the point that we want. And the third one is about prismless enamel. It is about 40 microns, and we prefer to eliminate it to increase the bondability. But in a fragment, we could use the prepless laminate veneer, and they are very good option for such a case, for a special case, for example, for peg lateral and the diastema. You have three different types of preparation. The first one is chisel or window preparation that is indicated when we want to change just the color of our teeth. So the contour of the teeth is acceptable, is our final contour, and we just change the color by this preparation. It is not so prevalent, but it could be used especially for upper premolars. The second preparation design is flat incisal or incisal butt joint that is very prevalent. We can add to the incisal edge by this technique. We can change the contour of proximal area. So the contour and color change is possible with this technique, and is very prevalent. The special point in this regard is rounding the line angle between incisal and labial angle. So the internal line angle should be round, as Dr. Mustafa mentioned. It is very important to reduce the stress problem. And the other preparation is our incisolingual wrap preparation. It is very useful when we have a thickened incisal edge. For example, when our incisal edge has been worn by upper, for example, restoration or something like that. This type of preparation could reduce the thickness of our incisal table after wearing a not incisal edge. And it will provide more better insertion path, but it is a little high demanding. By this preparation, again, we could change the contour beside the colors, and it is very good preparation, but we prefer butt preparation. It is less demanding. What about the cervical margin? Could it be upper, lower, or at the level of the gingiva? All of these margin could be used, but each preparation has its own indication. Supragingival margin could be used for restoration when the color of the tooth and the restoration is not so different, so noticeable. Since the patient searching for aesthetic are very demanding, we prefer to not to use supragingival margin. What about the lower gingiva, subgingival margin? Subgingival margin providing enough space for running room is indicated when we want to change the contour significantly, especially in diastema. Since the running room, it is provided but by the place of the restoration, place of the margin according to the gingival level, help us to have a restoration with gradually change contour and no step. But the margin at the level of the gingiva is our preference, or especially my preference. Another very important point in preparation is dogleg or galving. It is frequently forgotten. This extension toward the proximal area under the contact will cause an extension in our restoration. If we forget about this type of completing the preparation, such an appearance could be happen when the patient is seeing from the profile. You can see the margin and the difference between the color of restoration and tooth. So it is very important to use galving or dogleg preparation and extension. For preparation, we have two different procedure and methods that we can use. One of them is the depth cut when our contour is normal, but we want to change the color. And the other one is reduction guide when our indices has been made by predicting the final contour. I will discuss about it. The depth cut is used when we want to change only the color of our teeth. So the tooth itself is our contour guide. We use a guide burr, depth cut burr, or our burr of preparation to make enough space for our restoration. Then we eliminate the island remain between our preparation, and this is the final contour of preparation. It is not so conservative compared to the other method I will discuss, but it is very easy and less demanding. The other method introduced by Gary Burrell is reduction guide, and it is more predictable and useful when we want to change the contour. What does it mean? The patient has been referred and we want to change the contour of hair or his teeth. We make a wax up digitally or conventionally according to our best guess, according to what the patient wants. Then make an index. This index could be used to check the space available and could be used for making a mock-up. Mock-up, as Dr. Atri said, is very useful method to predict the final shape of the restoration and let the patient know what she or he should expect from our restoration. When the mock-up has been checked, evaluated, and finalized according to what the patient and clinician wants, we could put the depth cut inside the depth cut. It is very conservative as some of our preparation depth will be in the thickness of our resin, and so it is more conservative compared to the first scenario and method. After that, we eliminate the remaining material. If somewhere we have penetration toward the tooth structure, we complete the preparation, we complete the margin, and then go for the temporary and final restoration. It is one of the patients treated with this treatment. He was referred to our office, the temporary restoration, the depth cut, and the final restoration. I will discuss this patient completely in next step. Okay, we want to discuss about this digital workflow. In fact, we have an interconnected network for conventional and digital workflow that we could change between them in any steps. So if you have no scanner, if you have no milling machine in your office, you could start by conventional manner, and the laboratory technologies could go for digital steps after your, for example, impression or any steps that you should consider. Let's go for some case presentation. The first one is about the digital workflow that was done completely by digital workflow. And as you can see, the patient was referred. She was a 26 years old girl. And according to what you can see, the old restoration, the staining, disorientation, and all the problems caused she to be unsatisfied with her aesthetic. It is not really its satisfying appearance for a girl patient. The digital smile design was performed for her according to the dimension and shape of her face, according to the distance between the teeth, shape of the lips, and according to what Dr. Atri presented. The digital smile design was done. Then digital smile design was changed according to what we thought and the patient expected, and a printed cast was made. Mock-up is preferred to be done by hand in conventional manner. Why? Because in mock-up we have a resin, and somewhere the thickness of this resin material will be 0. So if we decide to make it by milling or 3D printing, we will have a very low thickness material, and it is in brittle mode. I mean, the PMMA or any material used for temporary restoration, it's very, when they are very thin, they are very brittle. So I, in my place, prefer to do the mock-up by hand procedure, by conventional manner. The mock-up was done, and the patient was led to evaluate the mock-up. After final change, the depth cut was prepared, and the preparation was done. In this step, the scanning was started. And as you can see in this technique, we could evaluate our preparation. And if anywhere the preparation is not acceptable or any undercut or any problem exists, we could just check the preparation and revise it just in that area, revise the scan, and everything will be okay. The scanner has some sound help that let us to know if the procedure is going correctly or any revision is necessary. After that, we will have a virtual model with a definite margin, and we could design a restoration on this model. As you can see, the restoration has been designed, and we can check it from different dimensions. Okay, let's go for the next slide. Then we decide which material to use. Since this patient was treated in office setting with office milling, so the temporary restoration was not necessary for her. We used lithium disilicate material, HTA2, in full contour mode, and the milling procedure has been done in clinical setting, office setting. And in the same day of preparation, the patient was delivered by the final restoration. As you can see, it is full contour lithium disilicate, and it is very aesthetically pleasant for the patient. And before and after picture for the patient. Okay, the next patient was treated by combination workflow. This is our patient with a problem of multiple diastema and some discoloration because of root canal therapy. The gingival leveling was done for her according to her gummy smile, and the mock-up was fabricated. After finalizing the mock-up, the preparation started in the mock-up with guide wire. And you can see some of the preparation depth is completely in the depth of our mock-up. And it is the finalized preparation. At this step, we make an impression. Since we decided to use framework layering technique, it is the impression sent to the laboratory. The laboratory could scan the impression or the poured cast by the impression. After scanning, the procedure of designing will be started by the technologist, the path of insertion, the designing, and it could be designed in full contour or framework mode according to what the clinician wants. So if it is in full contour, it will be completely milled from a material in one step. If it is framework layering, then we will need a cast, printed cast or impression cast for making the layering technique after fabrication of frameworks. In this step, we ask for the temporary restoration provided by the laboratory in PMMA material, polymethyl methacrylate, by milling. It is the PMMA material temporary restoration. And then the final restoration was made by a framework from lithium disilicate and layering by feldspathic ceramic porcelain. And you can see the starting and final results. It is very pleasing, I think. Okay, if the restoration and laminate veneer is done by for correct case and is done by correct procedure, the cumulative survival rate in 10 years is more than 95%. And it is very acceptable treatment modality for 10 years. And it is according to Alenzi article until 2021. So if we want to do it by digital workflow, the accuracy will be increased, the predictability will be increased. And as you see in the first case, the digital workflow will facilitate and increase the rate of fabricating of our restoration. If you have any question, you can ask me in my Instagram, or all the questions are welcome here. And thank you for your kind attention.
Thank you so much, Dr. Qudsi. It was very wonderful and very, can you hear us?
Yes, of course.
Yeah, very nice cases, very nice slides. And like usual, Dr. Sadapur, please start with questions.
Some questions.
Of
All right,
course.
thank you so much. It's a very useful and practical presentation. It's very nice that you started with the literature and you ended up with your recent practice case. And the outcomes are very amazing. And I'm sure that the patients are happy. And our colleagues, the dentists, they will make advantage of your knowledge and the result of your practice. And it's wonderful that you have an in-house lab that you can make the impression, you do this whole procedure from A to Z in the office, and you deliver the restorations in the office. And as you mentioned, that there was no need for temporary restoration, because in the laminate veneers, it's a big deal to make the temporary restoration. I have always headache with my patients. I make a chairside temporary restoration, and the day after, patient call me back that it's broken down and I don't have it, and they have to come back and make it again and again, and it's a painful procedure. Anyway, thank you so much. You made all the veneers with the latest products of the different ceramics. It was very informative and very useful. Thank you, dear.
Thank you again for all your efforts, all your help, and all the stresses you sustained in this program.
Yeah, but I think the result is very good, because our lectures today were excellent from the beginning, and to you that it was very wonderful. And so we give a recess to our audiences for about 15 minutes. Thank you so much, Dr. Qudsi, and goodbye to you.
Thank you again, and goodbye to all of my guests.
Goodbye.
All right. We do have a break from now for almost 20 minutes. All the audience, you will be, we're gonna give you the link for all the lectures so you can watch and take advantage of the presentation in the site of the Tehran University School of Dentistry. We're gonna write it down and give it to you later, so you can watch for the people who couldn't attend the meeting. Thank you.
At 11:30, we see you again. Thank you so much for now.
لینکشو گفتم میفرستم.
آره اینا مرتب بفرستیم که اونایی که نتونستن
are all familiar with conventional prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences School of Dentistry.
Hi everyone, my name is Soha. Did you know that Tehran University of Medical Sciences is the oldest and most well-known medical center in Iran, nationally and internationally?
Tehran University of Medical Sciences also has the largest school of dentistry in Iran. Take a look inside.
School of Dentistry is organizing its classes following health protocols. You will join large lecture classes like this.
Restorative Department of Dental School of TUMS to teach you restorative dentistry. Restorative dentistry is the main part of dentistry. Actually, it consists of two parts. Theoretical part
Or small practical classes like this.
I totally picked the right major. Have you picked yours? We've got TUMS in a School of Dentistry. Go to TUMS website and pick yours.
During studying, we have access to a wonderful hospital, giving us opportunity to have more experience.
And of course, sometimes you need to relax. Dentatory kulliyeti esnaf TUMS.
Hoş geldiniz. Bekliyoruz sizi.
We are waiting for you in a School of Dentistry TUMS.
Hi everyone, my name is Soha. Did you know that Tehran University of Medical Sciences is the oldest and most well-known medical center in Iran, nationally and internationally?
Tehran University of Medical Sciences also has the largest school of dentistry in Iran. Take a look inside.
School of Dentistry is organizing its classes following health protocols. You will join large lecture classes like this.
Restorative Department of Dental School of TUMS to teach you restorative dentistry. Restorative dentistry is the main part of dentistry. Actually, it consists of two parts. Theoretical part and
Or small practical classes like this.
I totally picked the right major. Have you picked yours? Digital TUMS in a School of Dentistry. Go to TUMS website and pick yours.
During studying, we have access to a wonderful hospital, giving us opportunity to have more experience.
And of course, sometimes you need to relax. لنتقل في كلية الأسنان في TUMS.
Hoş geldiniz. Bekliyoruz sizi. We are waiting for you in a School of Dentistry TUMS.
Dr. Sadehpour, can you hear us? Dr. Sadehpour, can you? No. Okay. Can you hear us?
Yes, I do.
Yeah. Dr. Sadehpour, I think we have to say this is the end of the break, and I'm going to introduce you to our audiences in 1 or 2 minutes, I think. Okay. So Dr. Sadehpour, I am going to introduce you. Dr. Sadehpour is a member of Tehran University of Medical Sciences, Department of Orthodontics. It's cooperating with us, and his topic is cements and cementation of CAD/CAM restorations. As I know, your postgraduate degree is from Laminate or UCLA, Dr. Sadehpour? Laminate.
USC. University of
USC.
California.
I'm sorry because I can't hear you completely. So Dr. Sadehpour is a specialist, as the degree of a specialist from USC, and he's He Saddam. He is our colleague that has helped me through these days and asking the questions. Not just me, he's asking the questions too. So Dr. Sarako, I think now we are ready to have your presentation, please.
Great, thank you so much. All right, hello everybody. We had 3 days course, and I hope that so far it was useful for everybody. I'm honored to join you in this meeting. This program is programmed and managed by Dr. Fari. She had so much effort to organize this meeting since 6 months ago, to arrange the topics, to invite the lecturers. And so far we had 3 days, and I hope it has been useful for everybody. And the IT part of the dental school, they provide the link for the people, for the audience, for the colleagues that they're interested to have these topics and lecture to watch and listen later on in their office. So they can have it through their through the links that we're gonna send it to you. So the topic here, as you see, it's cements and cementation for the CAD/CAM restorations. The objectives of each lecture, I introduced the indirect restorations, then I talked about cement, the difference between cementing, roofing, and bonding. I do categorize the dental cements. I go over to preparation, and then we go over the all ceramic restorations, which type of dental cements is proper for cementation, and then we gonna talk about a couple of cases, and I go and I give you some tips for cementations. All right. As the population age, the need for dental restorations increase. However, dental restorations can be made directly next to the dental chair or indirectly in the laboratory. So, indirect restoration is any restoration that's fabricated extraorally. We can have the CAD/CAM technology next to our dental chair, or it can be made by the lab technician in the laboratory. And we know recently some of the offices are equipped with the CAD/CAM technology in the office, but most of the CAD/CAM restorations are made by a lab technician in a dental laboratory. An indirect restoration in modern dentistry should fulfill at least 3 requirements: biocompatibility, durability, and aesthetics. Metal ceramic restorations have been in the market for more than 5 decades. Despite its success, the demand for improved aesthetics, especially in the anterior sextant, lead us to introduce all ceramic restorations. All ceramic restorations are an important part of dental treatment in contemporary dental practice. There are 2 factors that affect our success in these new type of restorations. First is the dental cement choice, and the other one how to use it. And the essential function of the dental cement is holding an indirect restoration in place for an indefinite period of time and filling the gap between the tooth and restoration. We have 2 types of cement. We have adhesive cement and conventional or non-adhesive glue. Adhesive cement include the categories of adhesive resin cement and self-adhesive resin cement, rely on both micromechanical retention and chemical bonding. But on the other hand, conventional cements, also known as non-adhesive cements, principally rely on micromechanical retention provided by a looping agent. We all are familiar with the zinc process cement. It has been in the market almost a century. If you do remember the gold crown provided design innovated by Dr. Tabak in 1907 with the lost wax technique, all of them have been placed and cemented by zinc phosphate. So it has a history of 100, close to 100 years old, and it was very successful. And you see the pictures, the cases in the book that they have been there. They lasted for more than 40 years. So we were happy with the zinc phosphate, the first non-adhesive or conventional cement. The second cement in this group is zinc polycarboxylate cement. This cement is an acid-base reaction cement that provides roofing action similar to zinc phosphate. But this cement, when I was at the school, at dental school in undergraduate program, I do remember we used to cement PFM crowns for the vital teeth with the zinc polycarboxylate and for the non-vital teeth with the zinc phosphate. That was the concept at the time. But now I know that the zinc polycarboxylate is not the proper cement to use as a permanent cement. We use it as a long-term provisional cement for the cases that we have to cement it for a long period of time. The third one is glass ionomer cement. It's the third non-adhesive cement in the market. It's a hybrid material combining the adherence properties of polycarboxylate with the long-term fluoride release of aluminum silicate. Physical properties vary widely depending on the powder liquid ratio. So the manufacturer's mixing instructions should be followed very carefully. And the last non-adhesive cement from the conventional family is resin modified glass ionomer or RMGI. Cements are designed to overcome the two main weaknesses of conventional glass ionomer cement, which is sensitivity to early moisture contamination and high solubility. Let's move on to the next group, which are adhesive cements. Adhesive cements are based on methacrylates modified composite resin and set through polymerization rather than acid-base reaction. They are an excellent choice when we are concerned about retention or aesthetic restorations made from glass ceramic or composite resins. The latest innovation, which they are self-adhesive resin cements, providing the ease of use associated with glass ionomer and resin-modified glass ionomer cements, but with higher strength, improved aesthetics, and dual curing. These cements contain specific adhesive monomers that are sufficiently acidic to enable self-adhesion without the need of a separate adhesive bonding agent. All of them could come in a version of light cure, self-cure, or dual cure. Here you see the variety of the light cure and dual cure. You see on the left side of the slide, they have Vela X veneer from 3M, Varilink veneer from Ivoclar, Calibra veneer from Dentsply Sirona, and GSM veneer from GC Company. And on the right side, you do have dual cure cements, for example, an X3 Nexus from Care Company, Calibra Universal from Dentsply, GSM 1 from GC Company, Relay XR from 3M, and Varilink 2 from Ivoclar. So making the right choice when choosing a dental set, the most important factors to consider are the restorative material and whether the preparation is retentive or non-retentive. We had very wonderful lectures today. Different lecturers, they mentioned about the principles of fixed orthodontic. Early morning, Dr. Mustafari, she showed you this slide regarding the 5 rules defined by Dr. Schillenberg. The first one was preservation of tooth structure. The second one is retention and resistance. I go over the factors provide retention for the restoration. Dr. Kaufman, his group, they did some experimental study and they announced that the length of opposing wall, tapering of opposing wall, and circumference of the tooth, these are 3 main factors that they provide retention for a restoration. And if we can't provide enough retention, we go with the auxiliary retention form like grooves, boxes, and isthmus. So Now we are familiar with the factors that provide retention for our restoration. Let's go on the different type of finishing lines. We have 5 finishing lines here. The one in the middle, the chamfer finishing line, it has been in the restorative dentistry for all the indirect restorations since almost 100 years ago for the full gold crown that we innovated by Dr. Tobart, by Lofsack's technique. So all of the full gold crown, we prepared the tooth like chamfer finishing line. Then we moved to PFM restorations when they were successful to bake porcelain and the metal framework. So the Rosnet group, they came up with the shoulder bevel. So they designed bevel, they provide enough space for the framework and the porcelain by this type of finishing line. And then later on, when the full ceramic restorations came out, we had shoulder design at the time. We had a sharp angle in the axogingival floor. Then we found that it should be round, and all the angles for the restoration, for the full ceramic restoration, should be rounded. So we ended up with modified shoulder and made round all the angles. Now again, since the ceramics were had a huge progress in the strength, so now again we are back with the chamfer finishing line, and we can have like 5/10 or 6/10 of millimeters in the lingual surface and 9/10 in the lateral surface of the restoration with the finishing line of chamfer. So by these definitions that I provided for you, a retentive preparation defined by axial height of 4 millimeters and above and tapering less than 20 degrees, we call it a retentive preparation. And if the axial height is less than 4 millimeters and the amount of tapering is above 20 degrees, we call it a non-retentive preparation. So depending on the clinical situation, the first question you should ask yourself, should I cement or bond? Here we have a case. We have a single unit tooth, it's prepared, the height of the tooth is fine, the tapering of the tooth is fine. So this is a retentive preparation. So we can go by the non-adhesive or conventional cement. I choose glass ionomer or resin modified glass ionomer to cement this type of abutments. There is another case that you see the margin is a kind of subgingival, so isolation is a big problem. So and it's almost not possible. So we go with the conventional cement because the adhesive cements, they are very technique sensitive. There is another case for the posterior teeth. When aesthetic is not a big deal, we do use glass ionomer or resin modified glass ionomer as a cement, which is enough as far as the cementation and qualification. And as you see here, there is a high carriage risk case which suffering from the dry mouth. For these type of patients, usually we go with the conventional cement and the family of the glass ionomer cement. And now we move to the preparation that we need to bond. And the preparation is not retentive. As the height of the abutment is short and convergences of the abutment over 20 degrees. So for these cases, we select adhesive resin cements or self-adhesive cements to cement the restoration. For the cases like these that we can isolate the abutment, for these options, self-adhesive and the family of the adhesive resin cements, they are the choice for cementation. Another case that we have to bond is aesthetically highly demand case, and the abutment is short, so we cement the case, cement the restoration with the family of the adhesive resin cement, which is self-adhesive or adhesive resin cement. And the last one, which is highly adhesion needed is ceramic veneers. We had a wonderful lecture by Dr. Otsi. She introduced us the different type of materials that we can provide veneers. So for these cases, the best option, the best cement would be self-adhesive or aesthetic resin cements. Now, I do categorize all the adhesive cements in 3 categories. The first one is aesthetic resin cements. These aesthetic resin cements require etching of the tube and priming or siloning the ceramic or the restoration surface. So we have both side surface treatments. It could come in dual cure or light cure, and it provides the highest bond strength for us. The second option, adhesive resin cements. For these type of cements, we do priming the tooth surface and we do priming a kind of silent for the restoration. And it comes in dual or light cure. And at the end, the family of the adhesive cement is self-adhesive resin cement, which there is no etching, no phosphoric acid or priming needed for the tooth or ceramic restoration. Can be bound directly to aluminum or zirconia. It comes in dual or light cure. So you see here huge variety of the aesthetic resin cement in the market. We do have Calibra by Dentsply Sirona on the right side. We have Relay X Veneer from 3M. We do have Canadian V5 from Quarry company, like the Noka the day before mentioned about the cement and he used cement for the restoration, some restoration with this type of cement. And on the middle, we have Choice 2 from Visco. It is one of the most available and best option in recent market. And here we see the adhesive resin cement. They have different families from same company, like Canadian 21 and Canadian F2 from Curare. We have Calibra Ceram from Additive, from Dentsply Sirona. We do have GSEM, Linkford from GC company, and Relay XR from 3M. So same company provide same different type of resin cement with their self-adhesive cements. So now we move on to the self-adhesive resin cement. Again, same component, the Curare provides Canadian SA, Fitsen from Fiberclub, GSEM Linkage from GC company, and we have GSEM 1 from GC company, and again, Calibra Universal from Dentsply Sirona. So all the best options in the market to use it easily and fast. All right, let's move on some cases that I have treated during the last 6-7 years, and we're gonna try different type of cements for different type of restoration. This lady, she came to my office. This is the maximum interpretation position, and as you see, if I draw a line from the canines, you see the central incisors are shorter than canines, which it doesn't look nice, and we call it reverse smile. So the patient knows that it's not beautiful, but she doesn't know what is wrong with that. Anyway, we provide enough data for the patient, and choice for this patient was laminate veneers, ceramic veneers. So I did small preparation. I kept the enamel to have the best bonding here, and you see the preparation is done. Isolate the area, core packing, and then I went through the impression material. I made the impression ready, and then for this case, which was an exception, I did prepare the teeth on the maxillary and the mandible at the same time, because as you saw before, we didn't have enough time to elongate the central incisors, so I had to ground the teeth on the mandibular arch. So I did the preparation, again, core packing, isolation, making the impression, and this is the definitive restoration. The of the page, and you see here, I did one composite for the tooth bicuspid. I usually go with the 6 anterior teeth if the patient insists on the premolar. I would tell the patient the best dentistry is no dentistry. So, but recently the patient they asked for the upper 8 teeth or 10 teeth, which I'm not a fan of it. Anyway, this is the close-up picture, this is the smile, and this is the profile. And she was happy. She came to me almost a couple of months ago for crown for the posterior area, and the veneers were lasting close to 7 years. This material was periscopic, the first group that Dr. Hotzi mentioned to that, and these are one of the most translucent veneers, and the Canadian F2 is the choice for cementation. It's a dual cube adhesive cement, which is very proper for this type of restoration. We move on with the next case. He's a young gentleman. He came from New York City to my office, and he was suffering from the diastema between the front teeth, and he had gone through so many dental offices to know that in the New York City there are plenty of dentists, they do aesthetic dentistry. So he was shopping around and asking different dentists, aesthetic dentists, how to fix it. So he was familiar with all of the options, all of the sermons, and there was no need to explain for him. So these type of cases are the best choice, best candidate for laminate veneers. Why? Because they have diastema and the teeth are small. So there is no need for too much preparation. So I did cleaning, brushing, shape selection, and then we move on with the preparation. You see, I just made the finishing line for the teeth, and here I do usually I do the immediate dental bonding sealing. It depends on which type of bonding sealing you believe, but no matter of the generation, it reduces the tooth sensitivity after cementation. So we always do that, and then this is the day of delivery. You see, I put the acid edge on the teeth. This is the acid edge. This is the red one. This is the only acid edge red. It comes from the company by Curare from Canada, and you see how the chalky surface of the teeth, of the lateral surface of the teeth, it shows that it's etched properly. So we go to deliver the restoration, and as you see here, we start from the midline, first central, then lateral, and then we go on to the canine. This is the profile of the patient at rest and exaggerated smile. The patient was so happy with the profile, with the aesthetic of the veneers, and since he was he was in trip, so he was here almost less than a week. So I couldn't follow up the patient and make picture after the healing phase, because since we do preparation and by court packing, by impression, so the gum are traumatized and we face with conversation at the day of delivery. But after a while, after patient brushing well and taking care of the teeth, we see that the papilla fill up these black triangles in the middle of the central. So I didn't have the chance to see this patient afterward, and he left here almost a week after and has been done 5 years ago. This is again a feldspathic veneers, the most translucent ceramic, and I cemented it with choice tool from Isco. This is one of the best cements and more reliable cements in the market. All right, let's move on with the next case. This lady, she was my student 5-6 years ago. She came to my office for consultation, and before me, she was visited by an orthodontist. And our local faculty, the orthodontist, he recommended to do orthodontics treatment for her to close up to that center. But for her, I recommended her, you know what? You are the perfect case for veneers. Why? Because your teeth, as far as the size, as far as the shape, they have to change. And sure, at the end of the orthodontics, you will not be happy with the shape and size of the teeth. So what we did, I recommend her not to close up the space. We're gonna gain a lot of advantage of this demo during the preparation. We made the data correction. We always take pictures in the rest smile and exaggerated smile, and then we have the maximum intercuspation position. As you see here, we have a canine in +5, so I know that's gonna bother me at the day of cementation. So we follow the instructions. We do a wax up. She was interested to do the 8-unit veneers. Again, I told her the best dentistry is no dentistry, so we ended up to 6-unit veneers. So I had the least preparation. I just made some margins for the crown, for the abutment. I did core packing, from the ultraband. So make the impression. You see here on the centrals on the labial surface, you can see the putty in the tray, which is shows that I had the minimum preparation. Then we did the shape selection, and this is the day of delivery, and you see how beautiful they are, and they have harmony with the existing dentition. I didn't make them very bleach, very wide, and I didn't elongate the teeth, and I didn't make it extra long central that people, our patients, they are really interested with the long central. It looks so natural. Just here we have some red spot on the right central because I made these veneers from lithium bisilicate. This one had a crack after cementation, but we had to remove it and make it over and re-cement. That's why here was traumatized, but it's just for the maybe first month after brushing and taking care of the teeth, the gums come back to the next position and next level. For this case, I did cement with the Panavia V5, which is the latest version of the Panavia, available by Curare company. Am I on time? How much left? Dr. Fari, am I on time? All right, let's move on. So,
yeah, please. Oh.
How many more minutes?
As much as you want. How much do you want?
I have 3 more cases to go.
Okay. I think our audiences will enjoy it because they are clinical cases.
Great. This guy, he came to my office and he's a middle-aged, tall guy, and he was suffering from the case. He was complaining that the teeth are very short and I don't like the space between the teeth. And when I took pictures, you see the occlusal shots of the case, you see all of them are worn down. And when we lose enamel, then we're gonna face with the rapid worning down the teeth because there's no protection on the teeth. So these cases, they have to reconstruct very fast to avoid more worning down. So as you see here, we made the primary information intraoral photograph. This is the maximum intercuspation position of the teeth, and you see how deep is the bite. The central incisors, they are biting and they're almost on the palate, and so probably I can guess that he has lost some vertical dimension. So articles recommend us. I made a bite guard for him, and I opened the bite with the least thickness of the 2 millimeters of the bite guard, and I delivered to him, and he was wearing it for almost close to 2 months. After he was satisfied with the height and with the sounds, I evaluate the patient again. So we moved on with temporary restoration, and I provisionalized all the teeth with deep grinding, and I delivered a full mouth lab fabricated provisionals for the patient. And you see the profile, you see the smile of the patient, you see the edge of the crown, they're following the lower lip of the patient. As Dr. Actually, she mentioned in the digital smile design, this is the way how we have to design the crowns. So these are the provisional restorations, and you see the lip support, you see the corner of the lip. So he was happy with the height of the crown. So he had it almost for 3 months. Then we moved on to make the final impression, always packing code, and you know how difficult to make the full mouth 14-unit crown impression. So please mention the height of the abutments, the one that I mentioned about the retentive preparation. All the abutments, they have height more than 4 millimeters, and as far as tapering, they're less than 20 degrees. So we consider that as a retentive preparation. The lab provided the crowns, and you see they have 14 units, single crowns, and the maxillary arch, and 14 units, single crowns, and the mandibular arch. And this is the case after 6 months. He was so happy with the appearance, and this patient going back and forth to United States and coming back, and I have a picture after 6 months. So you see the finishing, and you see how we did correct the vertical bite, and the bite now is established. The picture on the top is the way the patient presented to us, and the picture on the middle, this is the situation almost 6 months later. For this type of restoration, that we have enough retention and tapering was below 20 degrees. So I did choose RMGI. This is GC2, provided by GC company. For these cases, that's the choice. It's easy to manipulate, and it's easy to care and deliver the crown to the patient. See, the number of the crowns are allowed. So this type of self-fuse cement, they give me more time to, rather than the other self-fuse conventional cement. All right, this is another case, and the last case. This lady, she came to me. She's a very young girl, and she was suffering from the open bite. You see on the picture on the left side, she had anterior open bite, and she had diastema and general spacing between the central incisors. And basically, she was at the age of 18, and she was caring about aesthetics, so she wasn't satisfied with the aesthetic. So I described for her that they have to grind a little bit and make some finishing lines for the crown, for the veneers, and we do the most conservative preparation. And I make these veneers from layered zirconia. And this is the result. It has been done 2 years ago. 2 years ago, I make all the ceramic veneers with the zirconia veneers, and they're layered by feldspathy. So they are translucent zirconias. They're very successful, and I use aesthetic adhesive resin cement for cementation. And maybe during the 100 cases, I was telling Dr. Musnafari, maybe I faced 2 patients. They had 1 unit veneers fell off, which it doesn't matter. And I did re-sandblast it. I sent it back to the lab, and they sandblasted and cemented again. But the result is outstanding. They try trying session. It's very easy because I don't afraid of the fracture, any crack of the veneers. So I do trying, I apply fit checker multiple times without any fear of breakage. So, and you see as far as the shape, patient was so happy with the result. It's not bleach color, it's completely translucent, and you see here the result is very close to the dentition, existing dentition, and it looks very natural. The best beauty to me is the natural beauty, but some of the patients, they ask for the bleach colors, which is out of my hand. I hope you enjoyed the lecture, and I hope it was informative for you. Thank you for your time, and I'm honored to be here and accompany the best faculty in my home.
Okay, thank you so much, Dr. Salampour. It was very, very comprehensive, and like I have a few questions. May I ask it?
Sure.
Dr. Salampour, I think the terminology that quite has become common that divide the cement to two categories, cement and adhesive. In prosthodontic dentistry, it doesn't seem a very good category. I think we should say adhesive cements and non-adhesive cements. Perhaps it's better than to say cements and adhesives, because we all call them cements. We call it resin cement. We call it glass ionomer cement. We call all of them cement in prosthodontics, but perhaps in operative dentistry, they have this category, cements and adhesives. In prosthodontics, we all use them as cements, but some of them are adhesive bonding cements, and some of them are non-adhesive cements.
Right.
And about your, do you agree?
Yes, I do. Actually, I brought up the slides regarding that, the thing that you mentioned here. I categorize in the beginning adhesive and conventional cements.
Yeah,
so
exactly.
This is the first step that we categorize the cements.
Yeah, and the other point that you have in with zirconia patients, that you have used zirconia on them, you said that you have layered them, and I think the layering makes it very aesthetic. The point that because these are all very aesthetic. I think the point that makes them aesthetic, more aesthetic than the zirconia that is quite opaque is the layering that you have done on them with feldspathic porcelain or something else.
Right. In the beginning, the zirconia crowns were very white and like bleach color, but now we have multi-layer zirconia and translucent zirconia, which they provide for the veneers options, and when we layer it with the feldspathic, you see how it is whiter and it's translucent, and it looks, the finishing is very natural view. So the patient accepted it, and we took advantage of the strongness of the veneers. You know, we all suffering from the weakness of the feldspathic veneers. In the beginning, maybe one or two cases when we tried in the veneers, we faced with one fracture, so we have to do it over the lab technician. It was painful for him to make a veneer same color as the rest of the veneers, but with the zirconia veneers, I don't face with those fractures, and I do try with the fit checker a couple of times, and I'm confident to push it on the tooth. And so I'm really happy with the result. Since 2 years ago, I have done maybe more than 100 cases. Here we didn't have time to add all of the cases, but they're very successful, and they last same as Emax or feldspathic, that we are more comfortable with the bonding. So
yeah, exactly. Because I think for the feldspathic, especially, and they suggested that to bond it and bond adhesively, and then do the finishing and polishing of the cemented laminate, because they are very weak, and of course zirconia is more stronger, and so it can be done before cementation. Yeah, that's correct.
Avoid fracture.
Yeah, exactly. So thank you so much, Dr. Sadapur. It was very informative.
And the other room.
Yeah, please come back to the other room. Our next lecturer is Dr. Leila Payaminia. She is assistant professor in Department of Prosthodontics, School of Dentistry, Tehran University of Medical Sciences. Her topic is additive manufacturing technologies in dentistry. What we call it 3D printing, but of course 3D printing is has different technologies that do this for us. One of them is called 3D printing, and so it is necessary for all of us to be familiar with all of these technologies. With some of these technologies, it is easier to use metals, and with some other, it is good to use with non-metals like acrylics or other materials. And so Dr. Payaminia is going to talk about this topic, these different technologies for us. It is, again, in our opinion, is very helpful. This knowledge is necessary for deciding what you are doing later in your clinical practice. So Dr. Payaminia, good afternoon. Perhaps it's afternoon, yes, or yeah, it's in the morning. Hello, Dr. Payaminia. Can you hear me?
Hello, Dr. Farid.
Hello. So please start your slides, and the screen is yours. Please go on.
Thank you, of course. In the name of God, the compassionate, the merciful. The slide is up. Hello, everyone. Welcome to our Digital Esthetic Dentistry online course. I'm Leila Payaminia, and today I want to talk about additive manufacturing technology. Additive manufacturing technology, or AMT, has several synonyms: rapid prototyping, direct digital manufacturing, solid freeform fabrication, layered manufacturing, e-manufacturing, generative manufacturing, and the most known 3D printing. As you know, there are two basic approaches in digital manufacturing: subtractive manufacturing technology, in which material is selectively removed from a bulk by milling or machining, and in contrast, the additive manufacturing technology, in which materials are selectively fused or deposited typically in layers to form an object. And as you see, it will result in less waste material. Initially, rapid prototyping was used for R&D, for research and development, for testing designs before engaging in extensive manufacturing processes. But today, 3D printing has moved beyond prototyping, and it is used in diverse sectors such as food, toys, engineering, jewelry, medicine, and dentistry. Since additive manufacturing technology is capable of delivering precision within a few microns, and so it is gaining popularity in dentistry, and as you see, it has many dental applications. Such as dental models, wax upon frameworks, individual trays, aligners, orthodontic appliances, surgical guides, night guards, temporary denture bases, crown and bridge, and moreover, the hearing aids, of course. As any other technology, 3D printing has its own advantages and disadvantages. Design freedom is considered one of its advantages. It should be said that it is virtually unlimited what can be designed, including hollow devices, which is not feasible in subtractive manufacturing technology. The other advantage is producing complex geometry. A complex design by 3D printing can be produced in just one fabrication cycle, unlike in subtractive technology, in which different parts would need to be
produced and then assembled. The other is ease of use. The complexity of the system is in designing the STL file. However, it's virtually, the platform is virtually loaded. It's much like a click and the fabrication commences. The disadvantages of 3D printing are as follows. The initial cost, needing some finishing and post-processing steps, and limited range of materials which can be used in 3D printing. The concept of 3D printing can be traced back to the invention of 2D printers. However, rather than ink being deposited onto papers for 2D printing, 3D printers use a variety of material to create 3D objects from a digital file. Although the concept is simple, but the technology is complex and involves several distinct stages. The first stage is data acquisition, which can be the facial scan, an oral scan, or simply a cast scan. The next step is CAD designing the item using modeling software such as ExoCAD or T-Shape. And after that, the STL file is output to the 3D printer software in order to converting or slicing into G-code, which is the 3D printer language. And after the printing is done, the final stage is post-processing the 3D objects. Considering the STL file resolution, it should be noted that the closer the triangles will result in the higher resolution of the printed object. The majority of commercially available 3D printer processes build a part in sequential layers stacked vertically in Z-axis, and material is deposited in a plane transfers to this vertical axis in an XY plane, and layers are sequentially deposited. And depending on the process, additional support structures are often necessary to fix the parts during the printing process and support overhangs against the force of gravity. Unlike subtractive manufacturing technology or milling, there are widely different methods used in 3D printing technology. The 7 main categories can be broadly classified as follows: vat polymerization, material extrusion, powder bed fusion, material jetting, binder jetting, direct energy deposition, and sheet lamination. And except the last 2 methods, all others have dental applications. Stereolithographic or SLA is the first method of 3D printing, which was developed by Charles Hall in 1984. SLA is a kind of vat polymerization process, and it consists of a vat filled with a liquid. This liquid is a photosensitive polymer, which is cured by a light source. In SLA, the light source is a laser beam, which draws the pattern point by point, layer by layer, until the printing is finished. Form Labs and DWS are 2 of the most famous manufacturers of this technology. Let's watch a video about
Once the liquid
SLA.
thermoset resin is loaded in the vat and the digital instructions are programmed, the laser unit directs an ultraviolet beam to a reflective mirror. From there, a galvanomotor system steers the focused beam to the resin surface. First, the laser draws layers of the support structures, followed by actual part geometry. After a layer is imaged on the resin surface, an elevator system shifts the build platform down, and a recoater blade moves across the platform to apply the next layer of resin. The process is repeated layer by layer until the build is complete.
The printed objects by this technology, I mean SLA, are very detailed. They have they are very accurate and they have a very smooth surface. However, the limitations of this technology is its cost and time in comparison to other batch polymerization processes. So it's ideal for small detailed objects. This technology, SLA, in dentistry is used for printing surgical guides, provisional crowns and bridges, dental models, and custom trays. DLP, or digital light processing, is the other kind of batch polymerization process. It is a variation of SLA, but it uses a digital projector to project and cure the liquid. Just like SLA, the vat is filled with a photosensitive liquid, but here the light source is an arc lamp, and it uses a projector. It's not a laser, and it projects the entire layer of an image rather than drawing point by point, layer by layer, which was used in SLA. DLP reduces the printing time, less material is needed, which reduces the cost. SLA and DLP are both used in dentistry, and although SLA is far more accurate than DLP, but the speed, simplicity, and durability of DLP has made it the first choice of 3D printing, the first choice of dental professionals all over the world. It's the first choice of 3D printing between them. The other batch polymerization process is CDLP, continuous digital light processing. Just like DLP, it uses an entire image of layer rather than drawing point by point. And but the difference is that the light source here is LED and O2. The other difference, as the name implies, is that the platform continuously moves upward in the z-axis. So it speeds up the printing process and makes it even faster than DLP. And the printed objects are very detailed, they have very smooth surface, and they can also be flexible. The second main category of 3D printing process is material extrusion. FDM, or fused deposition modeling, is a trademark name of material extrusion devices. Also, it has a generic name of FFF, fused filament fabrication. In this technology, the material is often a solid filament, which is progressed through a heated nozzle, just like a glue gun, where the material is heated and it is extruded and then solidifies. This system is also capable of constructing a supporting structure of a different material, which can be then discarded by dissolving in a detergent or in water. Stratasys and Unimaker are two of the most famous manufacturers of FDM. Although this method is slower than SLA, but the printed objects have a high degree of detail and durability with excellent thermal, physical, and chemical properties. Wax filaments can be used to fabricate wax patterns of fixed and removable denture frameworks. The typical thickness of the layers is 25/100 of a millimeter in this technology. However, layers as fine as 400 of a millimeter could be printed with certain material. Powder bed fusion is the third main method of 3D printing. And SLS, selective laser sintering, is one of the famous kind of this technology. SLS is equal to SLA, but instead of using a bath of liquid, it uses a bath of powder. And this powder can be metal, can be ceramic, or photopolymerizing resin. The other difference is that SLS doesn't need any supporting structure because the object is encased with powder. However, it is found that residual stresses in this technology is high. The excess powder in the bath is also used for other printing processes, so it can be recycled. 3D system, EOS, and Sinteris are three of the most famous manufacturers of SLS. As the powder can be ceramic, metal, or plastic materials, its dental application is to fabricate all ceramic dental restorations, metal partial dental frameworks, and acrylic provisional processes. SLM or selective laser melting, is also known by the trademark name of DMLS, direct metal laser sintering, is similar to SLS, but exclusively uses metals. It's another kind of powder bed fusion, you know, the laser, the light source is laser, which selectively melts the metal powder. And unlike SLS, SLM requires a rigid support to avoid distortion of the object during printing process. And Renishaw is the most famous manufacturer of this technology in dental applications. Although the SLM is in SLM the printing process is lengthy, but it is capable of producing intricate designs like lattice and hollow in metal framework, which is ideal for cobalt chrome denture frameworks, metal copings for crowns, fixed partial denture frameworks, and full contour processes, and also custom-made dental implants. EBM or electron beam melting is another kind of powder bed fusion. It is very similar to SLM, but instead of laser, it uses an electron beam. And since the process takes place under vacuum, EBM is suitable for reactive materials with a high affinity for oxygen, such as CP titanium, which is used for fabricating implants. The limitations of this system is that the process is lengthy, expensive, and only conductive metals can be used. Multi-jet fusion, or MJF, is the last kind of powder bed fusion technology. It is relatively new, which was introduced in 2016, and it claims that it reduces the printing time by 10 times compared to other 3D printing processes. This process involves thermal energy rather than using a laser. The printed objects are very detailed, very smooth, resilient, and they are resistant to weathering and caustic chemical agents. One of its dental applications is to fabricate clear orthodontic aligners by thermoforming, like Invisalign. Material jetting is another kind of main category of 3D printing. Material jetting is similar to 2D inkjet printing, but it delivers a liquid photopolymer through a nozzle, drop by drop, to form layers, which is cured by UV light. The advantages of material jetting is its superior quality and speed, its high precision, and the uniqueness of material jetting process is that multicolor and multi-property materials can be selected for a single object. And the choice of material is also diverse. The drawbacks of this method is its high cost and potentially weak products. NPJ or nanoparticle jetting is another kind of material jetting method. It is identical to material jetting, but uses nanoparticles of metals or ceramics, which are delivered in an aqueous solution. It uses a thermal process instead of using UV. And after its application, the liquid evaporates and leaving a residue of metal and ceramics, which are forming the layers of the 3D printed object. DOD or drop on demand is another kind of material jetting method. This technology uses two nozzles instead of one. And one nozzle is using for a wax-like material, and the second one is using for printing a dissolvable support structure material, which is removed after printing, remaining just wax material as the final product. It is ideal for fabricating wax patterns for casting dental alloys. Binder jetting is another kind of 3D printing process. It uses a bonding agent to stick particles together to form successive layers, and it uses a powder bed of ceramic, gypsum, or metal. In this technology, also no support structure is required, as the process uses the powder bed for supporting the 3D printed object. This technology is relatively fast, inexpensive. However, the post-processing time is long and onerous, and the print object lacks structural integrity, and they are unsuitable for end use unless they are post-processed by infiltration of cyanoacrylate or epoxy resin to enhance their physical and mechanical properties. So it's ideal for prototypes, casting patterns, and gear structures. Post-processing steps, it depends on the type of the 3D printer process, and it may involve trimming support, removing excess powder in powder bed fusion 3D printing process, and dissolving the supporting structures and rinsing. The object may also require additional processing, such as UV curing, sandblasting, sealing, metal plating, infiltration, polishing, and sterilizing, and many, and just like these processes. Let's take a look at literature about 3D printer which are used in dental applications. Culver et al. Compared the trueness of CAD/CAM milled complete denture and 3D printed complete dentures. And in terms of trueness of interior surface, they concluded that CAD/CAM milled complete dentures were superior to 3D printed complete dentures, and 3D printed complete denture can be used as temporary because of their trueness of interior surface and also their strength. Austin et al. Compared the accuracy, internal fit, marginal fit, bonded strength, connection between the veneer porcelain, and also the fracture strength of the laser sintered dental processes and conventional casting technique in a review article. And the results showed that the laser sintering process seems to be an alternative technique to conventional casting. So they are helpful to fabricate fixed restoration, special processes, titanium implants, and surgical stents. Kosafa et al. Compared the accuracy of removable partial frameworks, which were fabricated by casting 3D printed pattern, and the frameworks which were fabricated by SLS. They compared these two systems, and they concluded that, however, overall discrepancies were smaller for the SLS frameworks compared to the casting frameworks. So the SLS frameworks were superior in terms of accuracy and reproducibility. Rio et al. Compared the marginal and internal fit of DLP-based 3D printed provisional crowns according to their build angles, and they showed that marginal fit were clinically acceptable in all build angles. However, internal fit was different depending on the build angles. Considering both the marginal and internal fit, they showed that 150 and 180 were recommended optimal build angles for provisional crowns. Jin et al. Also evaluated the effect of build angles on tissue surface adaptation of maxillary and mandibular denture bases manufactured by DLP process, and they showed that the surface adaptation was not statistically significant in 4 different build angles. However, they showed that the color deviation map also showed that the 135 for maxillary and 100 for mandibular were the optimal build angles for 3D printing the complete dentures. Wang et al. Also analyzed the trueness of zirconia crowns fabricated by 3D printing, and they evaluated the trueness of external surface, interior surface, marginal area, interior occlusal surface, and they showed that the 3D printed crowns was were no worse than the CAD/CAM milled zirconia crowns. So they might be suitable for fabricating zirconia crowns. Laminate also evaluated the load-bearing capacity of CAD/CAM 3D printed zirconia, CAD/CAM milled zirconia, and the heat-pressed lithium disilicate ultra thin occlusal veneers and molars, and they showed that despite statistically significant difference were found between these groups, but all groups showed that load-bearing capacities exceeded the clinically expected normal bite forces. So all groups were acceptable. However, further studies are needed on biomechanical, clinical, and specifically patient-centered outcome measures to determine the true superiority of one technique over the others. Thank you for your nice attention.
Thank you so much, Dr. Payamania. I think we have new technologies in 3D printing. Some of them were not last year. Yeah. Can you hear me?
Yes. Go on.
Some of the technologies were not last year. Some of the technologies that you talked about, 7, 8 technology. I think some of them were quite new, weren't they?
Yes, some of them are new, but you know, the SLA was introduced in 1984. But
Yeah,
some of the other
I think that
are very
the last 2 or 3, it was they were new. The last 2 or 3, like jetting, I think, like
material jetting.
Yeah. Dr. Paimania, do you know anything about this zirconia 3D printing? Is it something like casting? How they can 3D print zirconia?
You know, I said that they are the zirconia powder are delivered in an aqueous, you know, tank. The material and after heat application, the liquid evaporates, leaving a residue of ceramics, which are forming the layers. The technology.
Okay, and so the sintering happens there. They are sintered. The powders are powder particles are sintered together.
Yeah.
Yeah. Okay, Dr. Payani, you know that I always ask questions. I don't know if Dr. Salahpour has any questions too.
Thanks a lot for a wonderful presentation. We all enjoyed and we heard about technology, and looking forward to see you again next year here in the same symposium.
Yeah.
Great, thank you.
So goodbye to you, Dr. Payamania. We hope you have a good day.
Thank you.
Our next lecture is Dr. Somaye Khan, and the topic is about digital in maxillofacial patients. And you know that maxillofacial patients need a lot of good treatment, and they need to be to improve their quality of life. So Dr. Niakan is talking about this subject and digital, how digital can help these patients. Okay, Dr. Sadaqpour.
All right. Yes, Dr. Niakan, she's prosthodontist. She's a faculty member of Tehran School of Dentistry, and she has fellowship of maxillofacial prosthodontics. And you know, Tehran Dental School is one of the major sites for treatment of the maxillofacial patients. So if our colleagues, if you know patients, they are suffering from the you know, the patients that they face with the face surgery, they have lost one part of the nose, ears, maxilla or mandible. You can refer these type of patients to our department. We have multiple specialists in maxillofacial prosthodontics, and we do take care of these type of patients. Our lecturer, Dr. Niakan, she's presenting facial scanners in maxillofacial treatments. So if you hear us, please move on. Thank you.
Okay. Hello, everyone. I'm Somaye Niakan, prosthodontist and fellowship of maxillofacial prosthodontist. I'm the last speaker of this 3-day course. I hope you have enjoyed all valuable topics discussed so far. I'd like to give you an overview about maxillofacial prosthesis. Then I'm going to move on digital workflow in maxillofacial prosthesis and the benefits achieved from that. Are you similar with this type of prosthesis? Maxillofacial prosthesis and alternative to surgery for the rehabilitation of patients with facial disabilities, such as congenital, occur due to malignant disease or trauma, are need to replace parts of the face and missing areas of bone and soft tissue, and restore oral functions such as swallowing, speech, chewing, and with the main goal being to improve the quality of life of the patients. For clarity and more comprehensive description of maxillofacial prosthesis reconstruction, the defects were classified as extraoral, complex, intraoral, extraoral such as nasal, auricular, ocular, orbital, facial, intraoral such as maxilla, mandible, or mid-face. Complex is extraoral plus intraoral defects. As you can see in this slide, for fabrication maxillofacial prosthesis, we have two methods or two options to choose. Conventional method or advanced manufacturing. Conventional, each of them have advantages and disadvantages. I try to discuss in my lecture today. This picture shows the comparison of conventional and digital workflow for extraoral prosthesis manufacturing. For the conventional technique, an impression is taken of the defect and surrounding tissue, followed by a casting and wax off of the prosthesis, and then creating a mold. Low temperature vulcanized silicone elastomer is mixed and then poured into the mold. After polymerization of the silicone, the prosthesis is prepared. For the digital technology, three-dimensional scanning is performed using oral or facial scanner, followed by importing the files into a computer-aided design or CAD program. Designing the prosthesis and printing the mold in direct pass, or the final prosthesis directly using a 3D printer. The conventional procedure for maxillofacial prosthesis manufacturing involves several complex steps, are very traumatic for the patient, and rely on the skills of the maxillofacial team. The extent of the defect and the use of different types of materials make this procedure very difficult and challenging for the medical team, and uncomfortable and painful for the patient. For data acquisition in a conventional workflow, potential errors occurring with traditional process also include distortion of the facial soft tissue, obstruction of the airway by the pressure of the impression material, aspiration of the impression material when the defect is close to it, aspiration of the material, difficulty associated with retentive undercuts sometimes require additional surgery for impression material removal, and impaired impression due to a reduced mouth opening after skull contracture or radiotherapy for intraoral or complex defects. Furthermore, for an auricular defect, an impression of the contralateral healthy ear is needed. Impression taking is also extremely difficult for the patients, especially when they have large defect or claustrophobia. For young people or uncooperative individuals, The conventional impression taking procedure is usually not tolerated without sedation. As you can see, I summarize the disadvantages and advantages of the conventional methods. The difficulty for both patient and clinician, claustrophobia, aspiration of the impression materials, soft tissue deformations, impression materials, distortion, data loss due to fragility of the models, need of storage space for archiving are the disadvantages of this method. And the advantages of the method are simple and cost-effective. No need special equipment, has a truly three-dimensional model. Okay, digital workflow, computer-aided design and computer-aided manufacturing have opened a new approach to the fabrication of maxillofacial prosthesis. In digitized maxillofacial prosthesis, three main treatment procedures are considered: digitization or visualization, modeling and designing, and then manufacturing or rapid prototyping. In order to digitize the defect and surrounding area, CT scan, MRI, laser, surface scanner, intraoral scanner, optical scan systems, and 3D photogrammetry systems are used. These digitizing systems provide very clear topographic data of the patients. Therefore, the distortion that may be caused by the physical properties of the conventional impression materials are eliminated as the data are collected without touching the tissue. The created digital models are transferred to CAD/CAM and rapid prototyping technologies in order to form successful prototypes for intraoral and extraoral maxillofacial prosthesis with good contours and tissue adaptation. Modeling and designing is the other element of digitized prosthetic rehabilitation. Modeling techniques are mainly dependent on the type of data acquisition. Medical imaging data such as CT or MRI are usually offered as digital imaging and communication in medicine or DICOM data. In order to create a 3D model, DICOM data need to be rendered and saved as a standard transformation language or STL5 format. For other digitizer systems, obtained data can be directly saved as STL5 format. STL5 format is an open source based format which is easily accessible through most commercial software applications. This database allows for easy information exchange and communication among users. STL data can save into different formats. American Standard Code for Information Interchange or ASCII and or binary. The ASCII format is less commonly used due to the large size of the resultant file, but it can be easily modified for debugging purposes. The binary format is more complicated in its syntax, but generates smaller file sizes and is therefore used more often. For designing, there are many special software that are provided by the manufacturers for the design of various kinds of maxillofacial prosthetic restorations. Most of this software offer a comprehensive design and sculpting tool set, allowing for sculpture of the prosthesis, anatomical details, and the formation of virtual clay models into any form required. The software of CAD/CAM systems presently available on the market is being continuously improved. The latest construction possibility are continuously available to the user by means of updates. The final design prosthesis can be saved as STL file format and can also be virtually matched to the defect model and evaluated for rapid prototyping suitability before manufacturing process. Rapid prototyping techniques have been used in digitized maxillofacial prosthetic production. The unique characteristics of rapid prototyping is that models and or prostheses are produced by adding material from the main source layer by layer from a 3D model in which all layers are bound together. Through this technique, practitioner can easily manage the formation of inner details of complex structured substances and undercut areas. RP technology have been utilized effectively for fabrication of facial prostheses over the past decade. Although the conventional processing was still essential to make some of the definitive prostheses. RP model production to aid prosthesis fabrication has been a feasible procedure. Using this mold would remove the conventional processing and shorten overall procedures of making the prosthesis. Furthermore, the produced mold can be kept for multiple reproduction of prosthesis since the mold is long-lasting and allows the pouring multiple times. As you can see, three main treatment for the procedures that have been considered in digitized maxillofacial prosthesis summarized in the chart. The digital workflow requires the acquisition of the three-dimensional data of the patient depending on the type of the defect. If it is intraoral, further information on neighboring teeth or surrounding bone structure also needs to be registered. Medical scanning such as CT scan, MRI, or CBCT was used in many reported cases for defect data acquisition. The choice of the image data is extremely important. With low resolution images resulted in discrepancies from the actual anatomy, and a high resolution requires greater radiation exposure in the case of CT and CBCT scans. However, for intraoral and complex defects, the use of a CBCT scan is mandatory to collect all the necessary information. Besides that, if the defect was generated by the excision of a malignant lesion, a post-operative CBCT is performed anyway for assessing the risk of tumor recurrence. On the other side, surface scanners are the most used devices for defect data acquisition. However, the laser scanners used are unable to penetrate and register deeper design and defect concavities as medical scanning do. In most of the published studies, at least two capture methods were used to precisely register the anatomical structure. For rapid prototyping, The techniques that have been frequently used are selective laser sintering, stereolithography, inkjet-based system, fuse deposition modeling, and various materials have been commonly been used with this technique, such as wax, plastic, ceramics, and metal. The digital workflow requires the opposition of the 3D. Surface scanners are the most used device for defect data. Okay. Sorry. As you can see in the picture, Louis combined the use of a facial scanner and an intraoral scanner to acquire a digital scan for the fabrication of an orbital prosthesis. The digital impression was performed in 3 steps. A scan of the face by using a facial scanner, a scan on the unaffected orbit with an intraoral scanner, and matching of 2 scans. And then the final prosthesis was delivered to patient. In another case report, Gerald in 2015 reported these cases. A 4-year-old girl was referred for the fabrication of a nasal facial prosthesis. She had severe facial trauma leading to bilateral enucleation of the eyes, and she had lost her entire nose. Because of the age of the child and the recent trauma and her limited communication skills, the use of digital imaging, digital design, and additive manufacturing of the prosthetic mold with minimal direct patient contact was chosen for the fabrication of the prosthetic. As you can see at the left side, the photograph and patient digital image, and the right side you can see the patient and template donor 3D images, and then matching to a scan. In the left side, you can see definitive digital prosthesis and mold design, and process prosthesis with base shape, and then completed prosthesis and baby's happiness. Another case, Soik and Kakik reported a 24-year-old man missing right ear induced by a trauma. A magnet retained in auricular prosthesis was planned for the patient. 3D scanning was performed on the healthy side by using a 3-dimensional optical scanner, and the data were mirrored. The mirror image was then imported to software, and a virtual model of the future prosthesis was obtained for the defect side. A 3-dimensional printer was used to fabricate a negative mold for the mirror image by using additive manufacturing. Also, me and my colleagues treated this patient in my department. A 30-year-old woman reported to the Department of Prosthodontics of Tehran University of Medical Sciences for replacement of her missing right ear induced by and acid attack. Implant retained auricular prosthesis was planned for the patient. Three-dimensional scanning was performed on the healthy side by using a facial scanner, and the data were mirrored. The mirror image was then imported to software, and virtual model of the future prosthesis was obtained for the defect side. A three-dimensional printer was used to fabricate a wax model for mirror image by using additive manufacturing. As you can see, on scanning of the defect side was performed using intraoral scanner with two scan bodies. And then the resin model was printed and the analog were placed in their position. To confirm the correct position of the analog, the printed model, a verification jig was made and tried in on the patient's ear implants. Then a titanium bar attachment was designed and made with a milling machine. This time, the wax model with the acrylic substructure was tried in on the patient's face. It was then stained externally, and finally acceptable auricular prosthesis was delivered to the patient, and the patient completely satisfied. Another patient that referred to our department with partial nasal defect, we scanned the defect side with oral scanner and printed the acrylic resin model. After that, the silicone prosthesis was conventionally made and delivered. The procedure involved precision of brief physical interaction with the patient and resulted in a well-fitting aesthetic prosthetic. In conclusion, to date, the software and interface used to process and design maxillofacial prosthesis are expensive, not typical for this purpose, accessible only to very skilled dental professionals or to computer-aided design engineers. As the demand for a digital approach to maxillofacial rehabilitation increases, more support from the software designer or manufacturer will be necessary to create user-friendly and accessible models similar to those used in dental laboratories. Additive manufacturing technologies have advanced to include recent improvement in limited color printing of soft materials. This development may provide a way of directly printing a prosthesis in multiple materials that would closely match the color shades of the patient. This advanced may eventually lead to the ideal workflow of digital image capture, digital design, and direct printing of the prosthesis. There are the references which I used in my lecture. Finally, thank you for your attention, and you can in touch with me via Instagram or email, and I'm pleased to announce that the Department of Prosthodontics at Tehran University of Medical Sciences as a well-known active center in the country, and it is a pioneer in maxillofacial treatment as well as digital technology indications in this field. This center makes an important role in collaboration with neighbor countries in order to make big efforts in this branch of sciences. I declare my readiness for further cooperation in this field. Thank you for your attention.
Thank you so much, Dr. Niakan. God bless you, because you making people that are very need to have a better quality, or to enhance the quality of life. We all know such a defects have a very bad impression on the life, and you make it better. Thank you, and God bless you. So our audience, our participants, I say goodbye to you, because it is the last lecture, and it is a 1:15 p.m. I don't ask any question from you, and say goodbye to you, Dr. Niakan. Have a good day.
Thank you.
Our participants, thank you for staying with us, and your presence all these 3 days and about 15 hours encouraged us for further making further programs, and we hope you have enjoyed it. I think all of you were excellent. I should almost thank our abroad colleagues, Dr. Sultanzadeh, Dr. Beg, Mr. Gergov, Mr. Al-Hassini. Also, they uprise our program, and I hope that we can have them in our later programs too. And this program was recorded, and it will be published on the program website. The link that you registered yourself in a couple of weeks now, and should make acknowledgements. I should thank Dr. Mir Hashemi, the Vice Dean of International Affairs, his team, Dr. Panahinia, Dr. Madab Shoma, Ms. Ahmad. Would you please come? Everybody says that you have always, in these 3 days, they were as stressed as me. They did everything they could whenever the connection was interrupted. So, okay, just you come. Come, please, come. Ms. Ahmadzadeh, Dr. Panahinia, Dr. Muadab Shomar, Ms. Ahmadzadeh, these all, and Dr. Niakan, these all helped us a lot. And I'm so thankful because all these 3 days, they were in full stress to make this program to run smoothly without interrupt or in disconnections. And I should thank the Vice Dean of International Affairs of University. They helped us a lot, and many other that I can't name now. They have helped us, and so again, thank you to you. Thank you, our participants at the last time. Thank you so much. I'm very happy that you have enjoyed it. You have used it. Doha, and I don't know if the Hiva is another one in our international student. I'm so happy to see you, Doha, here, and the other ones if I don't name them. But I'm so grateful to them that you have been with us. Thank you so much. And now it's time you and all of us to leave. Thank you so much. Thank you. Thank you for being with us. Thanks a lot. And bye. Bye, everybody.
Yeah.